We are arthritis, subcategory degenerative, part one. So for convenience sake, we have divided the big topic of arthritis into four subcategories. And the reason for that is when we look at rheumatic diseases, which you can also simply refer to as any musculoskeletal disease, there's over 200 identified diseases in the group. What constitutes a rheumatic disease? Well, typically there's an inflammatory process, something that will obviously be able to affect joint components, but we also widen the group of tissues that include tendons, ligaments, as well as underlying bone and overlying muscles. Now, if we narrow it down just to really joint-specific problems, we still have over 100 named rheumatic joint conditions. So that presents quite a problem, since all of the target tissue, all the imaging is going to include some abnormality of joint spacing, joint alignment, or even joint contour. So really, what could go wrong with this? Well, it turns out a lot. So we've had to come up with a way to guide ourselves through this process, and really a systematic approach is required. So we already talked earlier in the introduction section about getting to the right category of bone disease. So here we are in the arthritis subcategory. We can further divide the arthritis group into subcategories of degenerative, inflammatory, metabolic, and septic arthritis. This will be helpful, and each one of them has some significant differences. So with a good job doing your ABCs for interpretation, harvesting good information, couple that with what you learn about the patient, more often than not, we can successfully get into the correct subcategory of arthritis. If we do what I call poster child thinking, and this is just, so if we did a retrospective study, took 1,000 patients with confirmed degenerative joint disease of some kind, and then we just recruited the first 1,000 people that fit that criteria, and then started looking at, well, what form of degenerative arthritis do you have? Whatever entity comes out with the most number of cases, that's who we determine to be our poster child. And that's a critically important decision to make, and will allow us to get into the right subcategory much more quickly. And then the information we find will have to either stand or fall on its own, and we can sometimes have to turn our back on the poster child and deal with a less common member of the group. So poster child thinking, very important to us, where we make note of the key clinical features. There are often differences in patient presentation. Certainly there's going to be opportunity for laboratory results to be useful to us, whether something is negative or positive. And then making note of the key radiographic findings, certainly of paramount importance to us. And then, of course, as I mentioned earlier, you'll have to factor in age. We sometimes use age to divide what would be likely in entities that look similar. Gender, we certainly have some examples of arthritis that are more, in fact, much more commonly found in women or men. Family history, presentation, distribution, review of systems, all of these things will have more or less significance depending on the specific case that we're working with. Lab findings, imaging findings, and then making use of statistics. What's likely? Again, you hear hoofbeats, horses. Every once in a while, it's not a horse. Then you got to go to the barnyard and take a look at the burro, the jackass. Very uncommonly, we're going to find out it's not a horse, not a burro. We have to go to the zoo and pick out some more exotic diagnosis. Now, this is assignment that you guys each need to do for yourself. I have in the file section, I put something titled Week 1-1. This is some background information, things to remind you yourself of, information you would largely have learned in previous semesters. Complete that to the full extent of your ability. And then secondly, there's the poster child assignment. I've got a framework for you to operate in. Just do your best to fill it out. And then, again, pay attention. Start making this part of your working information. So when we do category or subcategory thinking, you'll be prepared to do that. Again, we've got two excellent textbooks available to us, Essential Skeletal Radiology by Yoke Monroe, and, of course, take a look at Clinical Imaging by Mark Yorey. Either one or both will be able to easily meet your need. Well, let's review the kinds of joints that we deal with. It's probably been a while since you've thought about the various types. Fibrous joints are best evidenced by the connection of the radius and the ulna, or the tibia and the fibula. We also have the more interesting cartilaginous joints, whether we're talking about the disc, symphysis pubis, manubrial, sternal joint, or if we're talking about a synovial joint, the bigger group of synovial joints, SI, apophyseal, any joint bathed in synovial fluid. Of course, the fluid needs to be contained within a joint capsule, and we'll be paying attention to some of these to varying degrees. A little closer look at the fibrous joint. Great example up in the cranial vault as we take a look at the sutures, the interdigitating bones, irregular in contour, held together by Sharpie fibers, and still produce some level of mobility. Radius and ulnar joint surface, again, you can see these ligamentous attachments holding fibula to the tibia. Of course, there's other ligamentous attachments and so on. This is sometimes referred to as a syndesmosis type of joint, if you will. And, of course, we have the interosseous membrane that also holds these pairs of long bones together. Cartilaginous joints, we'll spend a fair bit of time taking a look at those. Here on the left is a discogram. The reason the image looks blurry, it was taken in a fluoroscopic setting. And we're seeing a part of a discogram. This right here is a needle that's been placed between the lamina, and they've inserted the needle into the center of the disc space and put a contrast agent in here that's largely and exclusively taken up by the nucleus pulposus. This is what a normal disc interior would look like. Again, you can see the needle track. Again, put the needle in the center of the disc, and a little less well contained, implying that there is some circumferential and or radial tears that are reducing the integrity of the container. And then here we are down here at L5S1. Again, you can see the needle track. They inserted the contrast, and it's just all over the place and getting very close to emerging outside the annular fibers. So again, discogram, very normal looking, on its way to pathology, very pathologic presentation in a fluoroscopic image. Artist sketch reminding us of the fact that nutrition and elimination of waste happens really by diffusion. We don't have any direct blood supply. Blood supply doesn't really penetrate very deeply into the annular structures at all. And again, we've got this kind of center space, if you will, where the nucleus pulposus, consisting of several proteins, including glycosaminoglycans molecules, a very water-loving molecule, is what is largely credited with maintaining vertebral body height and disc integrity and disc turgor, or disc pressure. Here's a cutaway view. You can, again, appreciate the multiple layers of the annular fibers. And then we get to the center. And obviously, this fresh cadaver, when sliced down the middle, some of the nucleus pulposus leaked out. You can see there's a potential space here. That will come important to us when we start looking at some forms of discogenic spondylosis where there's such thorough loss of disc spacing that it can produce what's called the vacuum phenomenon. We'll talk more about that at the right time. And then the last but not least, and again, we'll spend probably the most amount of time looking at synovial joints, sometimes simply referred to as a diarthrosis. Here we have two bones covered in articular cartilage joined by a joint capsule. And of course, we have a synovial joint cavity filled with synovial fluid. Fluid is produced by the synovium or synovial membrane, which is essentially very filtered blood. And you can see the marrow space end, and there's a remnant of a growth plate here, dividing the metaphysis from the epiphysis, and so on. This is one of the better artist renderings that I've seen. Even then, I would want you to know that this surface and this surface touch. There isn't any gap between these unless you're really pulling hard. Long axis distraction. Even then, there's a limit to how much separation of joint surface that you can get. I think it's important for us to know that these tissues are meant to be in contact, usually are in contact, and the articular cartilage has to have certain properties, cushioning properties, slipperiness, to allow for normal, fluid, painless joint motion for sure. So that's the end of degenerative part 1. All right, now we're going to continue, again, arthritis section, degenerative part 2. So we're going to take a closer look at the bigger category of chronic low back pain. Then we're going to kind of focus in on pathology that affects the disc. And then I definitely want us to know that we can sometimes be the difference between whether a patient gets surgery to deal with their problem or if we can lead them to a successful conclusion. So when we kind of take a step back, look at the big picture of chronic low back pain. When we look at causation, discopathy accounts for that pain only 1 to 3% of the time. Now, if you're in that group, you don't really care what the percentages are. You just know that your life is not the same as you like it to be. Now, when we take a look at a deeper dive, the intervertebral disc itself, because it has free nerve endings, is capable of being the pain generator. Obviously, the zygapophyseal joints very capable of producing pain, sometimes with sclerotogenous distribution of neurological complaint. Then, of course, the SI joints can also produce some problem that secondarily affect the disc for sure. Discopathy without radiculopathy. So we could have examples of disc prolapse, simple protrusion, extrusion, or herniation. That accounts for the bigger percentage, somewhere between 17 and 39% of chronic low back pain falls into this category here. Why the wide range? Well, multiple different trials have been done, and this attempts to capture the results of several studies. There's no one number that everybody is able to produce. So as I mentioned, the innervation of the intervertebral disc is such that it can be the pain generator. So we do need to pay attention to the disc as a possible source of a patient's presentation. We have to recognize that we also have played a role in the care of these patients and sometimes kind of unknowingly help them, or the reason we directed care towards the patient may not fully explain why they responded so well. We also have to pay attention to the fact that the actually nerve root has to pass in close proximity to the disc, usually in a posterolateral location as it exits out under the pedicle at the level above. And certainly nerve root compression producing segmental problems are not unheard of. Whenever we look at degeneration or degenerative change inside the disc, we know that there is a lack of turnover. The rate of injury exceeds the rate of repair. In younger patients, some of our patients just simply get old enough that they can't replace cells. All living tissues turn over, are replaced by newer, younger. Well, there's diminishing return as we age, and they just lose the ability, and they lose more cells than they can replace. And all of these conditions would fit into this degenerative disc disease matrix. Now, when we take a look at disc height, then for the most common, particularly treatable cause of disc degeneration is the loss of proteoglycan. You'll hear me refer to it sometimes simply as a GAG, or the glycosaminoglycans molecule, which is specifically designed to attract water. Multiples of its molecular weight in water it holds to it, very hydrophilic. That will allow the interior of the disc to be completely filled and under some pressure. That's one reason why when there's breach in the annular fibers, the nucleus pulposus will leak out because it's a hydraulic system under pressure, and pressurized systems will always exploit the weakest link, or the most easy pathway, path of least resistance, if you will. This comes out of Pain Physician 2018. Now, ideally, any intervention or biologic therapy for degenerative disc disease should at least resolve the discogenic pain, the nociceptive discogenic pain, and this can be accomplished by reduced inflammation amongst other mechanisms. Slow reverse the catabolic metabolism. This is the breaking down of the system, which under normal conditions would allow for the replacement with newer, younger, better. But when catabolism exceeds metabolism, then we end up with a degenerative scenario. We also would like to be able to regenerate or increase the production of proteoglycan. Those would constitute ideal therapies, and therapies that so far seem to be out of reach. We certainly know, and you should know by now as a trimester 6 student, that one of the ways to injure disc is by excessive mechanical load. And while the patient will often report a single event, I did this and I got that, it's important for us to know that there were likely precipitating events producing smaller amounts of injury, layers of injury, until finally the failure became quite apparent and large enough to rise to clinical recognition. The injury to a disc, we know, also stimulates some cell-mediated responses, but we'll talk in greater detail about that in a while. And it's now recognized that cytokines, particularly the inflammatory cytokines, which are produced by macrophages or could be the result of injured disc cells, they can directly produce pain, but they also add to the injury to the disc and kind of set up a cycle, if you will, that leads in more and more deterioration of the disc complex. This is just a remarkable group of images, obviously not of the same patient, but at the top we've got this very healthy disc. You can see the crisscrossing bands of annular fiber and containing the gelatinous nucleus pulposus in the center. This is obviously an older patient where the disc has started to dehydrate. We will talk about MRI imaging of a healthy to unhealthy disc, and one of the key markers of an unhealthy disc on MRI is the evidence of reduced fluid or water or dehydration. Now we've got such a degree of dehydration that we really have lost the boundaries. We don't see where the margins of the container which holds the nucleus pulposus more or less in the center. And now we've seen down here in this final picture a tremendous amount of reduced density, disc spacing between the superior and inferior end plate, very irregular articular contours of these vertebral bodies, a very disorganized matrix where you can still, that the outer layers are annulus fibrosis, but you also know this is where the space should be for the nucleus pulposus, and it's quite abnormal, quite intruded upon. So degenerative disc disease, or DDD for short. Pretty common. 90% of people over the age of 50 years of age have some level of degenerative disc disease. For some patients, it really is just simply the product of aging, and as I mentioned, the tissue can't replace itself. It gets to the end of its replication line, and it's no longer available and just goes away. But we also know younger, healthier discs can be injured by adverse loading, repeat loads, heavy loads. There are just some behaviors that just are not supposed to be produced by humans. Simple dehydration can also change biomechanics and increase the rate of wear and tear, and again constitutes a form of degenerative disc disease. Cellular apoptosis, this is really what I was talking about before, when all of a sudden the cell line ends and can't replace itself anymore. There was several years ago now, Nobel Prize was earned in biology when it was recognized that there's a gene in every cell line that is inactive, and as long as that gene stays inactive, that cell line can reproduce and replace itself. Once it becomes activated, that's the end of it. That cell line can't replace itself anymore. It was coined by the press the suicide gene, which I think is most unfortunate, but cellular apoptosis is what we're really talking about. MMP, TIMP, we'll talk about that. MMP is matrix metalloproteinase. It should be in balance with tissue inhibitor metalloproteinase. When we see the system shifted out of balance, it's usually because MMPs increase. Inflammatory cytokines and other proteolytic enzymes will increase and overwhelm the typical inhibitory effect of TIMPs. Now, current medical treatment options that we need to be aware of. As you move out of here into your own practice, you're going to have to engage in good, useful, informed consent, and surgery is one of the treatment options. But when good research is performed and review the outcomes months to years after, we find that most examples of surgical fusion, while they do tend to produce some short-term improvement, in the long run does not appear to be superior to conservative care. So you're going to meet patients that are, oh, if this doesn't work, I'll just get surgery. And there's a whole category of injury, iatrogenic injury produced by the treatment itself, a failed back surgery. So it's nothing a patient should enter into lightly. Use of disc spacers and replacement discs are increasing with varying levels of success. Injection therapy, of course, many of these pain clinics are really just trying to offer palliation, no real attempt at mitigation, just make them feel better. But more recently, we've seen some attempts to regenerate disc structures, whether it's with platelet-rich plasma, the so-called PRP injections, or more recently, mesenchymal stem cell, MSC. These are emerging. There's not great science behind them yet. It's not anything I can talk to a patient about and say, oh, yes, by gosh, go get this. It's going to help you. We're not there yet. We've got more to learn. Also, I'm aware Logan's participating in a study that's attempting to change the genetic profile, allowing disc components to essentially reset the clock to a younger time period and restore the ability to replicate and maintain its integrity. Very exciting possibility what lies there. Well, that leaves us with what we do best, our conservative care model. By far the cheapest and cost-effective. Now, that does require us to keep close watch on patients and make sure their neurologic status doesn't retreat or worsen. We don't help everybody by a long shot, but we help a lot of people, and very satisfied to help people who really come to us as last resort. So they're more afraid of surgery than what the chiropractor can do. And then, again, I'm happy to tell you that most of these patients will have a good result. Now, we are hopeful that regenerative medicine in the long run will become available. That really does offer the best and most complete treatment for these cases, but until that happens, we really need to be able to step up and help these patients, and I would like you to know we can. Now, prolapse disc. This is where part of the nucleus pulposus has extended out beyond the outer annular fibers. It's in the central canal. Sometimes they're silent. Other times they are up against the outside of the dural sleeve, and they create dural irritation, dural signs and symptoms. But there are times, particularly if it's above L1, where the cord can be compressed. Down below L1, where it's all cauda equina, we can sometimes see examples of entrapment and compression of cauda equina, still capable of producing segmental signs and symptoms. Now, for us to be able to successfully treat these, we have to know that we can do it, so we can sell this idea to the patient, because it's going to take some cooperation and a certain amount of toughness on their part, if you will. There's just some sketches here. Clearly, this would fall in the herniation category, but it hasn't extended beyond the confines of the outer annular fibers, so it's still contained. This is uncontained, and this one actually goes one step further because it's been separated from the parent nucleus, and this is now a sequestered fragment. So uncontained extrusions are more problematic than contained, generally speaking. Now, that's not to say if the contained disc bulge or herniation is in a position to compress an exiting nerve root, then yes, symptoms obviously can present. Now, regression or disappearance, what are we talking about? Well, sequestered fragment that has been taken care of by the body. I will tell you that when I sat in your chairs now over 3 decades ago, we were told that sequestered fragments were a green light to surgery. You had to get them into surgery as quick as possible. Well, now I understand why. If the body takes care of the sequestered fragment, it's not a billable service for the surgeon. So the surgeon needs to get in there quick, take something out, send it to pathology, and their massive bill will be paid. We need to be able to authoritatively speak against that. Now, here's what we know happens where the end result is resorption. When you have a herniation, particularly if it's an uncontained prolapse, and ideally a sequestered fragment, that will trigger inflammation, which is the body's messaging system. It's a chemical messaging system that now invites a cellular and histologic response, mostly in the form of macrophage activity, which phagocytize the foreign body, which is how this sequestered fragment will be interpreted by our immune system. If we can buy enough time for the macrophage phagocytic activity to continue, then we can see complete resorption, and I've got some cases to support that. So this comes out of the natural history of herniated nucleus pulposus with radiculopathy. It's an older paper, 1996, and for me the real shame is this is not really working knowledge within our profession. It's increasing, but my gosh, we've known about this for far too long to still have back surgery as common as it is. Another paper, histologic evidence of absorption of sequestration type herniated disc, definitely what we're talking about right now. And then the effect of transligamentous, this just means the portion of the nucleus pulposus has gone beyond the ligament attachments of the disc complex. And they actually include regression as well as resorption in here. Now, here's what one study did. I cherry-picked this study out. For not quite a 2-year period, this research group recruited 390 patients who were scheduled for discectomy and then some type of fusion surgery. They had to get the patients to agree that they would not undergo surgery for at least 2 months, unless, of course, there's evidence of progressive neurologic deficit, or if signs and symptoms of cauda became emergent, or if the patient was in such intolerable pain that nothing was able to really control it. Other than that, they were able to keep a significant number. Now, the only conservative care that they used really was bed rest, which we now know is one of the worst things to do for a patient like this, as well as the use of NSAIDs. They also, on occasion, use some nerve root blocks, again, just really pain management, if you will. Out of this initial group of 390, only 69 of them ended up in the hospital, and only 35 of this group needed discectomy. This is remarkable. Again, 390 patients scheduled for surgery and convinced them to wait about 2 months, and only 35 of them, so less than 10%, continued on to surgery. Now, if we can get patients to kind of put up with the pain, and it's not full blown, there are things that we can do. We know that stimulation of mechanoreceptors will dampen type C pain fibers. We know that use of other conservative pain control, anywhere from acupuncture to hot and cold packs, have been able to give the patient enough comfort, plus our treatments. So I'm going to show you a single patient who May in 1996 had a large left herniation L4, L5. So here we are. Here's the sacrum down here. This is an MR image. How do I know? Well, I know by shape this is the sacrum. I go to the outer layer where cortex is, and it's mostly black, very black up here in the front. I know this is the L5 vertebral body. Again, I'm going to go to the perimeter, and I see it's black, so I know it's MR. Now, here's the central canal. This is CSF. Here's cauda. You can see it's impacted by this rather large free fragment. And you can see the outline, the perimeter of this thing, so we know it's a sequestered fragment. Well, he got better, and pain retreated. But in September 1996, he acquired a new right herniation, L3, L4. So again, this is the same patient. Here's the sacrum. You can see his anterior lethesis is unchanged over the interval. And here we have here's 5, 4, 3, L3, and here we have the smaller, but still distorting the dural sleeve and compressing the cauda right here. And again, we can see there's one end of the nucleus pulposus, and then there's this free fragment right here. Well, that resolves. Now in 1998, he re-injures himself and has a new right herniation back down at L4, L5 again. So here we are back down here. Here's again the S1 segment. You can see the anterior lethesis. And now this is impressively large. Here's, as you leak nucleus pulposus out of here, these end plates get together. And we can see, again, a big chunk of it here, another chunk of it down here, all compressing most likely multiple portions of the cauda at this point. Well, finally, he either wised up or stopped injuring himself. In October 1999, here's his MRI. Again, the S1 segment here, still the anterior lethesis, but disc containment looks good. Disc containment looks good. Same thing up here. And this was all managed by conservative care. And as I look at what they did for conservative care, it's really incomplete. It's not anywhere near the full package of treatment options that we have available. So imagine if this patient was under chiropractic care. I can only imagine that it would be even quicker. So again, one patient, multiple disc herniations, conservatively managed, and complete resolution because the body was given time to do its work, clean up that, again, what appears to the body to be a foreign material. As the nucleus pulposus breaks off, it's not receiving any nutrition, can't eliminate waste, it ends up essentially dying. And in that death, it sends out chemical signaling that attracts the repair. So again, we know that this is what happens when herniation occurs, particularly when it leads to sequestration. You get local inflammation, the chemical messaging system, that induces phagocytic activity. And if we can keep the patient comfortable enough, doesn't mean pain-free, but comfortable enough, then we can expect full resolution and repair usually by scar tissue. Now, other things that we know we can do, well, adjustments certainly have great neurologic benefit, as I mentioned before. But we can do also other pain control. Some experts say that having the patient ingest proteolytic enzymes will help support the removal of the sequestered fragment. We certainly know rehabilitation gives the patient a certain amount of control over their recovery. Use of orthotics, maybe it was a leg length inequality or asymmetric pes planus or something along those lines that kind of set them up for this problem in the first place. Other things that we know, so that study I referred to put the patient in bed for quite a while. We know walking is more important. Good walking habits, standing upright, and that produces a greater and quicker resolution. Using adjustments or self-mobilization, maybe even some of the behaviors out of McKenzie. These are all parts of a good chiropractor's tool bag, and that helps explain our success with these patients. And then spinal stabilization using exercises, proprioceptive rehab, and proper use of orthotics. And the tears, I just want to talk a little bit about this. You've probably been interested, it's been interested in other classes, but this would be a circumferential tear, concentric tear, if you will. So these are more breaches between the layers, but then we also can have these radial tears where they are directed perpendicular to the annular fibers, and in the long run leads to the emergence, whether it's a contained or non-contained herniation for sure. We know that the inflammation triggered by the injury can in its own right produce pain, but we can also see some spillover to the nerve roots, producing essentially a chemical radiculitis. Walking, many benefits: muscular effects, stimulation of mechanoreceptors. It helps with neurologic stimulation, helps keep the brain acquainted with the body part. There's certainly psychological benefits. Being trapped in bed, hurting, every move sends jolts of pain to your back and or down your leg. It just feels better when you can be up and moving, even if it's slow, even if it's a little bit uncomfortable. Now, I want to talk a little bit about MRI and discopathy, particularly in a degenerative setting. I've had the great pleasure to spend time with Dr. Michael Modic, who first put this work together for us. The so-called modic changes, or sometimes referred to as physiologic changes, takes us through the various phases from normal disc to abnormal disc. And when MRI was first becoming routinely available, some of the imaging of what turned out to be simple DJD was really frankly startling, and a lot of false positive reports were written, and I would say that even led to unnecessary surgery. But thanks to Michael Modic's work, we now have a very clear understanding of what's going on and aren't going to fall for it. We greatly reduced the rate of false positives through his work. So again, Dr. Michael Modic, professor of radiology at Case Western in Cleveland, and way back in 1988 he wrote this. And I think it's critically important for us chiropractors because we see an awful lot of disc pain patients, and they increasingly are coming in with their own MRI and or CT discs, and I think it's important for us to be conversant in this arena here. So Modic divided those physiologic changes into three subtypes: type 1, type 2, type 3. And I just summarized them here, and I've got pictures to support. So I'm going to encourage you to say, okay, Modic, type 1, down on 1, up on 2. Now, what are we talking about? Well, remember, the tissue that is a bright signal or an intense signal on T1 weighted MRI images is typically fat. And if we want to see water density or edema, you're going to need a T2 weighted image. And a simple stupid memory is H2O will show up best on T2 weighted images. So we want to overemphasize the two, if you will. But what we see here is a change from normal marrow to now infiltrated marrow by edema or water. And this represents a more acute process, and that usually means it's the first change, the first departure from normal. When we study these things histologically, of course, when patients are done with them, they die for some reason, and then we do thin section and staining, we recognize that we see disruption and fissuring of the end plate, and we see vascularized fibrous tissues within the adjacent marrow, and then, of course, we see the associated change, in this case, infiltration by edema. So again, we know that this is an MR image by finding bone. Looking at the outer layer, it's black, dense bone, doesn't have much mobile hydrogen, so it can't emit signal for us to record and create an image out of. Decide whether you're dealing with a T1 weighted image or a T2 weighted image. I'm going to suggest you look at in the central canal at the CSF. So again, what gets highlighted is fat. That explains this hypertensus, this epidural fat here. In this vertebral pair, L4 and L5, we see a kind of roundish looking decrease in signal intensity. Well, that's what would happen if water displaced the marrow signature. Take the patient over to the T2 weighted image, again, go to the central canal, and I can see it's brighter. So we're seeing the result of water, which is the large constituent of cerebral spinal fluid. You can also see nicely a little better hydration at the L2, L3 disc, not much in the way of hydration at the L3, L4 disc. And this is probably edema signature as we're seeing the increased intensity here. So again, type 1 is down on 1, up on 2, and that represents a little more of an acute process in the degenerative disc disease continuum. Now, type 2 is where we find most patients, and we think every type 2 started out as a type 1. But those type 1 patients don't often have enough complaint or a serious enough complaint to move them into an MRI setting. Not so with the type 2 patients. So most common in that it's where we find most of our symptomatic patients. Now in this case, we're going to see increased signal on T1 and either an equal intensity, iso intense, or a slightly hyper intense signal on T2. Now what we see on the T1 image is the result of fatty degeneration of subchondral marrow. And again, what does a T1 image highlight? What's most intense on a T1 image in MRI? Well, fat. This tells us that we're dealing with a more chronic process here. We've seen conversion from now edema-laden marrow into fatty marrow, fatty degeneration. Yellow marrow, another way to talk about fatty marrow replacement in the vertebral body. We believe that all type 1s will eventually become type 2s, and every type 2 started out as a type 1. Now, type 2 can remain stable for a long time, but some of these patients will migrate into type 3. Now, here's a pretty typical type 2. Again, take a look at the central canal. The CSF is black, so we know for sure we're dealing with the T1 weighted image over here. Look over here again, brighter signal in the central canal, so here's the T2 weighted image. In identification of the type 2 Modic change, I'm going to recommend you look at the T1 weighted image because it's the only one that will have increased signal intensity at the end plates as we take a look at the L5S1 disc space here. As we move over and take a look at the T2 weighted image, we still see has a level of hyperintensity to it that we can only explain by edema. So I would look at this patient and say, this is an early type 2. They've begun the fatty degeneration process, which is why we have these hyperintense zones on the T1 weighted image, but they also have remaining some of the edema, a carryover from the first phase, if you will. Now, if we were to come back some years from now, my prediction would be that we would see a more easily identifiable up signal or hyperintense signal on the T1 weighted images, and now it would be iso intense on the T2 weighted images as the fatty marrow conversion has completely displaced the edema signature. Last but not least is the Modic type 3 or physiologic change type 3, where we have a decreased signal on both T1 and T2 weighted images. This represents extensive bony sclerosis that we sometimes refer to as subchondral sclerosis, seen on plain film radiographs, and of course CT. On an MRI study, because of the dense bone, and for the same reason, cortical margins will look dark or low signal intensity on a MR image, dense bone will appear similarly, so it's a reduced signal environment. Histologic examination shows dense woven bone. As we increase the bone density in the region, we're going to see less and less mobile hydrogen. We're going to displace marrow, and it will impact the resulting MRI image. So here we have, again, at two levels, really L4 and L5, these little zones of decreased signal, a little thicker zone here. Again, a thicker zone of reduced signal here. And when we take a look at the T2 weighted image, again, we've got this thicker decreased zone here and up here and up here, all of it telling us that there's dense bone in that location. Would we ever need to do an MRI to identify type 3 finding? No. Your plain film and or CT image will be plenty. Once you see that density, I would like you to be able to predict that what it would look like on MR is a type 3 Modic change, down on 1, down on 2. Just an example of some of the attempts to replace living tissue with artificial structures, and there's varying degrees of success. I think the patient does need to very much limit their activity, so it really is not a return to your previous life kind of scenario. Failure, it remains a common problem here as we've seen complete disruption of this version of a disc replacement, and while this is in place to help us identify the center, you can clearly see it's extending beyond, and this part has failed, and they will have exaggerated movement and very painful movement as a result of this. And that concludes the Degenerative Part 2 lecture. Okay, now we'll continue with Degenerative Part 3. So we're going to take a closer look at synovial joints. We're going to do the extremities first. So first we need to take a look at how do we define degenerative joint disease? What does it consist of? Well, we certainly recognize it by the gradual loss of articular cartilage thickness. So we're going to lose those properties of cushioning and, of course, kind of slipperiness, if you will. When you lose cushion, that will produce a pretty persistent stimulus to underlying bone, creating piezoelectric stimulation, which leads to thickening of subchondral bone. It's denser. We often refer to that radiographically as subchondral sclerosis. And then we can see bony outgrowth, sometimes referred to as osteophytes, bone spurs, if you will, out at the joint margin. And they usually will follow the contour of the outer annular fibers to a great degree. And then more recently, we recognize on the inside of the joint space, we have kind of a non-specific synovial inflammation. Now, we still will recognize DJD overall as a non-inflammatory arthritis, but we have to recognize that the body uses a chemical messaging system by and large, and so there is some low-level local inflammation. DJD, or degenerative joint disease, less commonly referred to as osteoarthritis, is really the most common joint disorder in the world by far. It also turns out it's the most common co-presenting arthritis in the world, and sometimes it arrives independently. We will see examples of both the DJD and another arthritis called DISH in the same patient, and we are confident that one didn't lead to the other. But there's going to be times where we see juvenile chronic arthritis like Still's disease, destabilize and change biomechanics that even as Still's disease burns out, stop progressing, it leaves behind the environment that leads to degenerative joint disease. So we've got both. Most common joint disorder in the world, for sure. Also the most common co-presenting arthritis, so sometimes we'll be diagnosing the same two different arthritis in one individual. About 1/3 of all 65-year-olds affected, according to research. But I have to say, in my reading practice, when I see a 65-year-old patient or older without DJD, I actually first suspect that they made an error with the patient's age or date. So it does happen, where I see really good-looking spines in older patients, but the people that present to chiropractors' offices and then subsequently get imaged generally demonstrate some level of degenerative joint disease. Younger than the age of 50, we see more men than women diagnosed with degenerative joint disease, and a lot of that has to do with some of the choices men make, the work they do, and so on. I've seen a couple studies that compared the mechanisms that lead to DJD in men and women, and what the striking difference is really is decision making. There's some things, you put a boy, a bike, and a ramp together, and somebody's going to be jumping something, and sometimes they hit the landing, and sometimes the landing hits them. Women are a little bit more likely to take a look at those three things and say, wait, let me get my camera and let me watch you. Now, once we get over the age of 50, we start seeing more diagnoses of DJD in women than we do in men. Well, that does not have to do with decision making. That most likely has to do with change in hormone, and it just is increasingly difficult for a woman to have normal turnover and maintain joint integrity. When we take a look at DJD, there is a definite predilection for weight-bearing joints of the lower extremity, cervical and lumbar spine, and some joints of the hands for sure. That kind of fits our wear and tear model for progression of DJD. But we also know that there are some histochemical factors that drive DJD forward, and I'll share some exemplary stories in a bit. So DJD causes, or etiologies. We certainly know that there are some local factors that do that, and we have to deal with both primary forms of DJD, which are sometimes the age-related, where the change in the patient's ability, the reduced ability to maintain tissue and have tissue turnover, is one form of primary DJD. But we also know that there are some joints that really never had a chance. The articular cartilage was never built right, and even normal loads would quickly wear out the articular cartilage and start the sequence of events that lead to acquisition of primary DJD rather. Now, secondary DJD is by far the bigger category. Simple things like a patient carrying around too much weight. This is certainly a risk factor for me. I continuously try to battle it. I still have to deal with it. Injury, whether it's in the occupational setting or in a recreational setting, again involves the joint and may very well lead to the acquisition of DJD. There are some skeletal anomalies. I'm thinking the lumbosacrofacial segment type 2A produces both arthritis at that accessory joint, but also produces conditions of disc injury at a very high rate. When we take a closer look at the knee, it's recognized that reduced quadricep strength makes the knee more vulnerable to DJD. And not too strangely, patients with knee pain can sometimes get a great resolution, great reduction in pain by simply strengthening muscles across the knee joint, so your quads as well as hamstring and gastroc. Increasing the integrity of those tissues reduces the strain and stress. And this can be taken to other body parts. Why not an ankle? Why not the shoulder? Why not in the spine of the neck? Just those studies haven't been done in abundance. We do know that there's some systemic factors. This is the reduction in estrogen levels that we know largely accounts for the increased diagnosis of DJD in women over the age of 50. We do believe there's some genetic susceptibility. Similar age patients with related family members can demonstrate worse presentations, or even the other end of the spectrum are less likely to demonstrate DJD because of their genetic coding. More recently, we recognize that low intake of vitamin D and vitamin C can contribute to an environment that leads to DJD progression. We have some crystal deposition diseases like CPPD that can destabilize the joint, and we get an overlay of DJD, hemophilia, Paget's disease, a tumor-like condition. And again, most of the seronegative and seropositive arthritis can also be either co-presenting or the consequence of DJD. So let's take a closer look. This is, again, we're talking about synovial joints mostly. There is some parallel with cartilaginous joints, but mostly we're directing this information towards synovial joints. The first phase, the first change that we see, edema and microcrack. So first, recognize what would it take to see a microcrack? Well, you have to take that histologic sample, look at it through a microscope. So these are not going to be defects that are visible to the naked eye, honestly. The edema component, some of this relates to what we just talked about in the previous section, the modic changes. We know that subchondral bone early on we'll start seeing infiltration of edema in our own marrow, producing an uptick in signal intensity on T2 wave images. Now, these studies were arrived at independently, but it's nice when different focuses of research kind of join together and support each other, in this case, by accident. Well, along with this microcrack, we start seeing edema, extracellular matrix. Cartilage will lose its smoothness. So now imagine, remember, it's supposed to be slippery, it's supposed to be smooth, it's supposed to be cushioning. Well, these things will compromise those prime functions. In the microcrack, you have to recognize that's a space now. and it represents a focal loss of chondrocytes. They're really important cells that help maintain cartilage integrity. And then at the edges of these microcracks, we start seeing areas of chondrocyte proliferation, which again tends to further produce a lack of smoothness or irregularity of contour. Well, in the second phase, as you imagine, microcracks are going to continue to get bigger. They typically will deepen in the direction of the tangential forces applied to it, and sometimes along the fibrils of collagen that hold the system together. Fissuring and pitting is the catch definition for phase 2. And again, we're going to start really seeing these clustered chondrocytes appearing at the edges of clefts, and again, really increase the irregular contour. And again, just think of the knee, think of the shoulder, and now these surfaces rubbing against each other as they go across the irregularity of the joint surface now. Yes, last but not least is the erosion phase, where we start seeing fragmentation of cartilage. It can break off. Joint mouse would be one way to look at this. Now, these loose fragments, they're no longer able to receive nutrition from the epiphysis, which is what supplies the entrance of nutrient and allows for the removal of waste product. These loose fragments, as they break off now, essentially die. And that starts that chemical cascade that has the body recognize that there's something needs to be cleaned up. There's foreign invader debris that needs to be dealt with. Now, this fragment causing mild inflammation. This is, again, relatively new information, but it doesn't really change how we parse out this bigger category of arthritis. While there is clearly an inflammatory process that's very local to inside the joint here, where when we turn our attention to rheumatoid arthritis, the poster child for the inflammatory category, multiple systems are involved for sure. Now, another part of this erosion phase, as we start getting fragments of cartilage to detach, we now make the underlying bone more vulnerable, the covering is thinner, and we can hydraulically inject synovial fluid into and forming chambers, these microcysts or subchondral cysts, because they do get large enough to be visible on even plain film images. So again, the 3 stages of DJD I think are very important for us to know. Phase 1, the edema and microcrack phase with its attendant information. Phase 2, fissure and pitting. You can just imagine everything is bigger, worse, and now certainly associated with some level of discomfort. And then finally, the erosion phase. Again, creates opportunity for us to see evidence of this on even plain film images now. So again, pathogenesis. Normal cartilage will turn over unless interfered with. And it does live in a essentially homeostatic state where cartilage breakdown and cartilage replacement happen, one right after the other, with the net effect being normal-looking, normal-functioning articular cartilage. We do know that the drive for turnover tissue is driven by chondrocytes, and it's these chondrocytes that release the collagens, proteoglycans, and the enzymes that we use to break down tissue break linkages to allow replacement to occur. And as long as we end up having the breakdown equal to the buildup, we end up with normal joint cartilage. One way to take a look at DJD is that we're really seeing a failure of chondrocyte synthesis. So we're not able to produce the collagens and the proteoglycans, or they're overproducing proteinases, and we exceed the ability for normal turnover. Abnormal chondrocyte synthesis is really the core of DJD, particularly in synovial joints. And we know that chondrocytes can be activated by cytokines. We also know that lipid mediators, particularly prostaglandins, and certain free radicals like nitrous oxide or peroxide, H2O2, can produce these abnormal chondrocyte conditions. And then we have portions of the cartilage matrix itself, particularly fibronectin, that are capable of, again, producing abnormal chondrocyte activity and promoting the conditions that lead to DJD. So when you are reading about activated chondrocytes, I want you to know that this is bad. An activated chondrocyte is one that is producing pro-inflammatory mediators, and it ends up producing conditions of catabolism or breakdown quicker than the body can replace it. I do wish sincerely that the people that came before us would have come up with a different phrasing for this, because I have to say intuitively, activated chondrocyte sounds like a good thing in an abnormal chondrocyte setting. But no, bad, it's in red, and then we have to recognize that what they're talking about is really the degradation process of particular cartilage. Now, when we take a look at normal and abnormal breakdown of cartilage, whether it's part of homeostasis and replacement or if it's part of the degenerative pathway, we're going to be dealing with 2 groups of enzymes here. Matrix metalloproteinases, or MMP for short, are sort of the most potent, and again, they are important for normal turnover. But when they are created in excess, they can overwhelm TIMP, which is tissue inhibitor metalloproteinase. As long as MMP and TIMP are in balance, so we end up with a normal turnover, normal cartilage integrity. And what we see mostly is an increase in matrix metalloproteinases, overwhelming the body's ability to produce tissue inhibitor metalloproteinases, and we have more breakdown than we do buildup, and we end up with a net loss of cartilage thickness, cartilage function, and therefore cartilage integrity. We also know another enzyme more recently identified is called aggrecanase. And again, aggrecanase can be seen under normal conditions. It helps break the aggregate apart, and again, allowing for replacement of older portions of the articular cartilage. But when created in excess, it again overwhelms TIMP, and we have a cartilage degradation scenario. Now again, remember, DJD is the poster child for the degenerative arthritis group, and it is clearly considered to be largely non-inflammatory. We do have local inflammation, these inflammatory cytokines stimulating or activating chondrocytes to release cartilage-degrading enzymes. And again, don't forget about other things, lipid mediators like prostaglandins, the eicosanoids. They also can activate chondrocytes to increase synthesis of MMP, tipping the balance towards degradation. Now, as you can imagine, there are drug companies out trying to maybe produce an environment that would reduce MMP production, which sounds good on the surface, except virtually every tissue in the human body that turns over has some MMP and TIMP balance scenario. So we have not been able to be very selective with MMP suppression, and it produces more widespread effects than simply to the joint. Well, maybe it's important to try to increase TIMP, increase the muting ability of the body. Well, again, we haven't been able to specialize those functions to just joint tissue, and then we end up with tissue that really can't turn over because the system is so thoroughly inhibited, the cells tend to just die in place. Nitric oxide, this is a tough one. We know we need nitric oxide for certain bodily functions. I've seen evidence that nitric oxide should be greatly increased because it's a beneficial role in human metabolism, but also we have to recognize that it is free radical and it can produce harm, so in moderation. Some studies have suggested nitric oxide might have a protective role, but then I can find almost an equally thick stack that suggests it has a destructive role. So I do not advise patients to supplement nitric oxide with the goal to be improving the joint function and joint pain. And I'm going to walk through some of the bigger joints, and the hip is a good one. Hip is a commonly involved joint in the DJD scenario. The non-uniform loss of joint space is one of the radiographic features that will help us identify DJD from virtually every other form of arthritis that can affect the joint. And I hope you remember when you did your rank-and-metric section in prior semesters that we find it useful to measure both the superior part of the femoral acetabular joint, the medial most part, sometimes called the teardrop distance, and then the axial component, which is more or less in the middle of the femoral head extending towards the acetabular articular surface. The superior measure is what is affected first and foremost in your typical case of OA. In some cases, that will produce a widening, or an apparent widening, of the medial measure, again, sometimes called the teardrop distance, if you will. I'll talk a little bit more about Waldenstrom in a couple of slides, but Waldenstrom's life work revolved around the pelvis and hips, and he left us with some very useful information. Other things that we would expect to see on a joint affected by DJD, particularly hip, is osteophytes. We tend to see them on the acetabular margin first. We can find them on the femur head, but it's going to turn out that the frog leg view, or where we externally rotate the femur to put the femur in more or less a lateral position and then take the image in that position, it's easier to find femoral osteophytes in that position. It's considered to be the most sensitive. But if you see osteophyte formation along the acetabular margin, you know you're dealing with DJD, because DJD is the only arthritis to produce true osteophytes. Now, we also tend to see subchondral bone cysts. Again, go back to the erosion phase of degenerative joint disease, where we've got fragmentation of cartilage, where that thins the cartilage protection for the underlying bone. And again, remember, these joint spaces are filled with fluid. It's a hydraulic scenario, and we can hydraulically inject, just with normal use of the joint, synovial fluid through these weakened and thinned articular cartilage components, and we can chamber out or see chambers of synovial fluid, and usually blood mixed in there because there's some displacement and fracture of trabecular bone and displacement of marrow and so on. Sclerosis, particularly on the acetabular side, we'll see these discrepancies in subchondral sclerosis, or sclerosis immediately adjacent to the articular surface, and that really has to do with the difference in mechanical strength. The femur is so long, its cortex has to be thicker for it to function as an effective lever. The acetabulum mostly is just going to bear down on top of the femur head, so when there are degenerative conditions, we find the acetabulum has to change more quickly than the femur head does. We'll see that in other areas. Cortical buttressing, thickening of the cortex, particularly on the medial side of the femur neck. These, again, are really a stress-related phenomena. And then we can see deformity of the articular surface, particularly the femur head, and then we may see some change on the acetabular roof of the superior margin. This is one of my patients. I would, believe it or not, put her in the success category because she came to me in her late 50s and was told that she needed total joint replacement, and wanted to know what I thought about that. And one of the things I pointed out to her was she comes from a long-lived family, and these total hip replacements last somewhere between 10 and 15 years, maybe 20 if you take really good care of it. And at her age, that would mean she would likely need to have a revision. A revision of a total hip replacement is also called a bone sacrificing procedure. So you have to carve out the part and underlying bone to make room for the new part, and none of that sounded good there. Plus, she has a very good job that she wanted to keep doing. It involves her to be active, and she was not looking forward to the 6 month or so rehabilitation process that is part of a good total hip replacement rehabilitation. So she wanted to know if I could keep her mobile enough until she could get older. She was targeting age 65 and be able to have total hip replacement at that time. So take a look at this. This really is demonstrating everything. Take a look at the good side here. Again, you can see joint spacing between the acetabulum and the femur head. Femur head contour is nice and smooth and round. Teardrop distance, axial distance, all really pretty good. Another hallmark feature of DJD is its asymmetric presentation, where in this case the right side looks much better than the left side. But even within the joint space, there's virtually no superior joint spacing left, and it looks like the teardrop is a little wider here. And again, a lot of it has to do with the laxity that's been produced into the joint capsule and the reduction in the superior joint spacing can kind of make this appear worse than it is. Out here, clearly this is an osteophyte off the acetabular side, and this bump right here at the margin of the femur head, osteophyte. And then this depression and this chamber, yes, you're right, subchondral sclerosis. So she's got the total package, and things occur more or less in this manner. Decreased joint space, followed by subchondral sclerosis. If you look at this area here, it's infiltrated with bone density, more so than this side, which is more lucid. So decreased joint space, subchondral sclerosis, marginal osteophytes, 2 locations, and sometimes subchondral cysts. So again, just close up view. She also has calcified myoma. She's got some fecal material ready to exit. SI joints look like they're holding up pretty well. Symphysis pubis definitely holding up very well. And we were able to get every bit of 5 years out of this hip before she, I remember her asking, when will I know it's the right time for surgery? And I looked at her and I said, when you can't take it anymore. And that was more or less the way it happened. This is, again, my patient. We're looking at the frog leg view. And again, we can appreciate the reduction in joint spacing. Now we can see more easily the femoral osteophyte, and as well as the acetabular osteophyte. Redemonstration of the cyst. The other femoral cyst we made a little harder to see because now looking through the femur head to identify it. I mentioned Waldenstrom before, so we got to be a little careful. So Waldenstrom allowed us, he's credited with some 40,000 dissections of the human pelvis. And he did most of this work before Willie Rankin stayed late in the lab, so he was doing it based on dissections. And he did focus on the teardrop distance, and we have 2 rules that he arrived at and have served us well through the centuries, really. The first rule is no teardrop distance should ever exceed 11 millimeters. No teardrop distance should ever exceed 11 millimeters. That almost certainly could be the first stage of an inflammatory process where the articular cartilage is thickened and swollen that will push the bony elements apart. We also see that in early cases of infection, where again the cartilage is now swollen and thickened because of the infection process, and again forcing the femur head, in this case, out. He also tells us that no teardrop distance should be different from one side to the other by more than 2 millimeters. So if I go back to this patient here, if I measure this teardrop distance and then this teardrop distance, it's pretty clear that this one's a little bit bigger by more than 2 millimeters, and not that we would ever suspect that this was a normal joint. But still, Waldenstrom's work allowed us to know that when comparing right side to left side, measuring the teardrop distance, no teardrop distance should ever exceed 2 millimeters. It should be 2 millimeters bigger, and it certainly should be 2 millimeters smaller. If it is, we can call it abnormal. We also know that no teardrop distance should ever exceed 11 millimeters, and those are usually serious causes. There's 3 main causes. I've already mentioned the inflammatory arthritis in the earliest stage, the septic arthritis in the early stage, but also hemarthrosis, simply released blood because of injury into the joint space, will also create an inflammatory event that will cause cartilage swelling. Here we've got such a degree of joint capsule laxity that in this case, the femur head, when the patient's weight bearing, is beginning to move out, greatly increasing the teardrop distance. So there are some mechanical changes in weight bearing patients that can produce this. Now, if they were on the tabletop, relaxed, then the femur tends to relocate, and we would be able to appreciate the not just the superior joint space narrowing, but the axial and likely teardrop reduction as well. Another example of a pretty thorough DJD scenario, large osteophytes on both the acetabular side as well as the femur head side, starting to see some of the buttressing that was mentioned, and we certainly have lost the round shape of the femur head here. And again, decreased joint space, subchondral sclerosis, bony hypertrophy or marginal osteophytes, and I don't see clear evidence of subchondral cyst here. I believe we've got a cyst here and a cyst here. So the subchondral cysts are sometimes seen. The other 3 things happen more or less in that order. Okay, moving on down, another weight-bearing joint that frequently suffers from DJD, or sometimes called osteoarthritis. We find weight-bearing and prior injury as key components of the knee DJD scenario. We also will tend to see non-uniform loss of joint spacing in this area as well. Subchondral sclerosis, again, because of the increased load, small osteophytes more likely to be seen on the tibial side than the femur side. And some loose bodies, which again represent the erosion phase of the 3rd stage of cartilage DJD in a synovial joint. Then deformity, change in Q angle, and so on. So we take a look at this image over here. Hopefully we can appreciate the loss of medial compartment. Medial compartment of the femoral tibial joint is most common. And in this case, we have osteophytes both on the tibial plateau, but beginning to present themselves on the femoral portion of the joint space. Normally in the middle, we find 2 peaks of the tibial eminentiae, and the femur is settled down so thoroughly because of thinning of the articular cartilage that it's remodeled and flattened those tibial eminences. Another example, different patient farther down the DJD line, a very thorough loss of joint spacing on the medial side, really medial subluxation of the femur versus the tibia. And again, in this case, tibial osteophyte formation, but not much in the way of no evidence of femur. We also have to recognize that the patellofemoral joint can become bound up in this DJD of the knee scenario. A little earlier example, again, medial compartment, the very beginnings of an osteophyte formation. We still can see the tibial eminence is starting to get blunted just a little bit here, but not very seriously. And because of the change in load here, we can start seeing what appears to be a little widening. It's not uncommon for actually the lateral collateral ligament to be very sore, or the lateral part of the patellar retinaculum, even though it's this side that's the more abnormal part. Again, look at the bone density here, bone density over here. You can see it's thicker generally. So again, decreased joint space, subchondral sclerosis, and a small osteophyte. Very typical, and again, mostly occurring in that order. I partnered this early DJD image with this further down the road. And in this case, the osteophyte has grown around. And I don't think there's any intelligence to this, but it does serve to reduce joint motion, but also will turn to reduce the joint ability to subluxate as well. Clearly rounding of the medial tibial eminence, and we're seeing change in contour on both articular surfaces. So when we take a look at the compartment of the knee and their presentation of DJD, medial femoral tibial joint is by far the most common. It's almost exclusively post-traumatic events where maybe seen in football where an athlete is struck on the lateral side of the knee complex, and it produces a very abrupt impact between the lateral femoral condyle and the lateral tibial plateau. That can change conditions in the joint to produce DJD, but again, mostly expected, predicted in the medial compartment. And then patellofemoral, it can be first, but definitely will follow femoral tibial DJD. Decreasing medial joint space, it's a pretty good idea if you can produce weight-bearing, at least AP films, because you'll get your best representation of the joint spacing on that view. Sclerosis and osteophytes, not very prominent, but visible in most circumstances. Sharpening or blunting of the tibial eminence is typical. The farther down the DJD line is, the more folded over or rounded it gets. Loose bodies, again, 3rd stage erosion phase of DJD. You can see 1 joint mouse, sometimes a couple joint mice. Subchondral cyst, less common than in the hip, but still not 0. And then varus deformity, with particularly egregious loss of compartment space on one side, opening the gap on the other side. A little closer look at the patellofemoral joint here, usually found in combination with femoral tibial DJD. There are examples of isolated, and they can be seen in like kickers, soccer players, where we have pretty prominent forceful contraction of quadricep. But we also can see patellofemoral DJD arise in a secondary DJD scenario where a crystal deposition disease known as calcium pyrophosphate dihydrate, we'll talk much more about that when we get to the metabolic section, can change the articular cartilage characteristics and set the groundwork for a subsequent degenerative joint disease presentation. So what do we see? Well, like you'll see in every DJD joint virtually, loss of joint spacing. We do see it more pronounced on the lateral portion of the articular surface, a little opposite scenario than the femoral tibial. Certainly osteophytes in play, sclerosis very likely. And strangely, and I can't completely explain it, we have this evidence of erosion of the anterior cortical margin of the patella. That's a good example to show you. Sometimes it's called the tooth sign, sometimes sawtooth sign. So this is the more typical presentation of femoral tibial DJD. I hope you remember from your anatomy class, your typical patella is going to have 2 facets, a short facet, this is on the medial component, and then a longer facet. I know our anatomists used to try to trick us by putting the patella out on the table and say identify right or left. If you could find a little dimple on the patella, put that down towards the floor, and then whichever way the patella fell, if it fell to the left, then you knew it was the left patella. Fell to the right, you knew it was the right one. Now, what we're seeing here on this later cell, let me finish it. So here we got, again, your typical subchondral sclerosis. The joint spacing is a little difficult to evaluate and judge, but if you have subchondral sclerosis, like we do here, you can bet the farm that we've got loss of cartilage thickness and integrity. And if you didn't appreciate the subchondral sclerosis, you have to deal with the osteophytes. And you should easily see these if you're doing your big white line assessment. How could you miss it? We also have this big osteophyte on the femoral side. So you see osteophytes, continuous cortex, bone growth at the joint margin. It's an osteophyte. And that tells you that the third stage of DJD, decreased joint space, subchondral sclerosis, marginal osteophytes. Now look at this one. This is subluxated quite far to the lateral. And we also have it remodeled over the lateral femoral condyle. And we have evidence of a big cyst here in the lateral femoral condyle. So very much a classic case of patellofemoral DJD. It's even got the sawtooth or tooth appearance on the anterior margin, as does this one. But lateral migration and remodeling, making this a particularly serious presentation. All right, moving on down to the ankle and the tarsal joint. Relatively uncommon site. We almost always see it in conjunction with previous trauma. We can even see tibial-fibular diastasis. This is where we've got permanent separation of the joint space, usually because of lack of integrity in the retaining ligamentous structures. And produces a very unstable scenario in the lower extremity. Tarsal is even less commonly involved than the ankle, but it can be. And when we do see tarsal involvement, it's usually the first tarsal metatarsal joint. So here we have ankle mortise joint. We see some thinning of the tibial-talar joint space. We also see some companion change between tibia and fibula and fibulo-talar. And we've got the artist rendering again, showing us the changes following the three-step process. First microcrack edema, followed by fissure and pitting, and then ending with a good chance at a loss of cartilage integrity or erosion phase. Here we have an ankle more seriously involved, evidence of debris, prominent loss of joint spacing, both tibial-talar, fibulo-talar, tibial-fibula. So a more serious presentation of DJD. Taking a look at the foot now, the first metatarsal phalangeal joint is by far the most common site. It makes sense when we talk about normal gait cycle ending in toe off. Well, it really is the great toe that we're talking about. Notice it's not toes off, it's toe off. Osteophytes again, both on the dorsal and medial surfaces of the first metatarsal head. We also can see the sesamoids under the big toe, the hallux. Also demonstrates some degenerative change as well. And there have been examples that kind of simulated gout, but when we did the biopsy, no uric acid crystals, no sodium monourate, so we were able to give the news as a simple DJD. In some ways unfortunate because gout you can treat, and DJD is a little bit more difficult to manage, particularly in the foot. Deformity, loss of joint space, sclerosis, subchondral cyst. Hopefully these are just familiar phrases to you, and I hope you've appreciated that no matter where you go in the body, because it's a synovial joint. Here's the features of DJD, regardless of what joint we're looking at. So again, artist rendering, identifying the first metatarsal phalangeal joint as the target. You can see the change in articular contour. The white arrows here are talking about thickened subchondral bone as well as thinning of the joint spacing. I mean, look at the second metatarsal phalangeal joint, how generous it is compared to here. These changes out here are all dealing with the combination of sesamoid DJD as well as the distal head of the metatarsal. Now, moving up to the shoulder, the ball and socket joint. We're in the shoulder complex. Between the glenohumeral joint and the corbiclavicular joint, the AC joint is the most common site of attack. And this is also one area that can produce a challenge for us. It really is the only joint space I really remember that can present with subchondral sclerosis, marginal osteophytes, but a widened joint space. These are almost always post-traumatic examples. Patients landed on their shoulder, had a distractive injury to the AC joint, changed joint integrity, and otherwise created conditions for a DJD of the AC joint. But even on non-weighted views, the AC joint will gap open. And again, we're signaling the post-traumatic scenario. If we were dealing with DJD in a weightlifter, so no traumatic events, just a lot of wear and tear, what I tend to see is the more classic reduction in joint spacing, subchondral sclerosis, and marginal osteophytes, and the occasional subchondral cyst. When we have OA in the glenohumeral joint, we really should be considering that there has been previous and/or significant trauma. They may also have underlying cartilage disease. Again, calcium pyrophosphate dihydrate is one of those crystal deposition diseases that can induce conditions for DJD. A very rare enzyme deficiency that can produce an arthritis, ochronosis, and the product of elevated levels of growth hormone, acromegaly. We can see joint cartilage thickening because that tissue will respond to growth hormone in excess. We'll get cartilage growth in excess, and that will add compressive forces and, again, constitute premature or accelerated wear and tear. So typically, AC joint OA, loss of joint space, but again, please remember, the post-traumatic distractive injury of the AC joint can have widening of the joint space and every other feature, sclerosis, osteophytes, and even subchondral cysts. Here we are looking at an MR image, and again, this kind of very hard to identify cloud. The AC joint is mostly abnormal. You can even appreciate the change in contour of the overlying soft tissues. Look at how nice and neat the humeral head is. Now, it is in a cephalad position versus the glenoid, so this leads me to suspect that there's rotator cuff injury. Here's the supraspinatus coming right through here to plug in on the greater tubercle and, of course, deltoid complex overlying the whole thing. Here's a very poor ultrasound image. This reminds me of we have better ultrasound images, and I need to just get one out of our holdings since we do such a good job with diagnostic ultrasound here. Glenohumeral joint OA, still in the shoulder complex. We do tend to see, again, non-uniform loss of joint space, subchondral sclerosis, osteophyte formation, and particularly common on the inferior portion of the humeral head. Every once in a while, you'll see it on the superior part of the humeral head and/or glenoid. Here we have, again, a pretty typical presentation. We've got subchondral sclerosis here. This person is not in the best position to identify joint spacing. That's called the Grassi position. Here is a properly positioned shoulder image where we have good recognition of the narrowed joint space, osteophyte right here, and again, look how remodeled and flattened the humeral head is. So it's not only the femur head that can change contour in cases of DJD. We are often seeing rotator cuff degeneration as part of this process that ends up producing DJD. We can see small cyst formation in the tuberosity. This is more of an enthesopathy. Anytime you've got soft tissue plug into bone, that represents an enthesis. I would say the more common feature on plain film is going to be recognition of the superior migration of the humerus as it relates to the glenoid cavity. This is because the injured rotator cuff will become inhibited, and now the normal tone of the deltoid will cause cephalad migration and close down what we call the acromio-humeral space, this distance right here. You can imagine there's not much room for the supraspinatus muscle to pass through here and become tendinous at the insertion. Again, here we have an MR image. We've got the chromion here, we've got the deltoid here, supraspinatus coming through here, glenoid, and look at the offset. Here's the inferior part of the humeral articulation. Here is the inferior part of the glenoid. This is cephalad, and that's closed down, compressed. These are the conditions typical of impingement syndrome. Look on this plain film image. We've got pretty much the full meal deal here. Asymmetric joint spacing. We definitely have osteophytes on both the humeral head as well as the glenoid. Subchondral sclerosis is more difficult to appreciate in the shoulder, but if you've got osteophytes, you know you've got the conditions for subchondral sclerosis. This joint even has a subchondral cyst. And again, look at, you know that the supraspinatus tendon has to pass through here. I can't imagine the discomfort this patient would feel during abduction. Now, impingement syndrome is a clinical diagnosis, but we can sometimes support the clinical diagnosis with radiography. That's how I would frame these images. Moving down to the elbow, secondary to previous trauma, almost certainly, occupation and recreational sources of injury are in play. We can again appreciate on occasion loose body formation, which does again represent the third stage of the DJD pathway. Osteophytes, spurs on the olecranon, particularly the triceps tendon insertion, all of these are the kind of features that we would expect to see in a good example of elbow DJD. So here we have the ulna across the joint, we've got the radial head here, and we've got some sign of periarticular osteophyte formation. We also have some defects in the articular cartilage on the capitellar surface. Remember, we divide the humeral head into capitellar and trochlear surfaces. Trochlear surface is the articulation for the ulna. Capitellar is where the caput or head of the radius is meant to articulate. And again, we've got the artist rendering telling us about the local inflammation attendant to DJD in the elbow joint. Down to the wrist is often the first metacarpal trapezium joint that we find at the base of the thumb. Is another way to look at that. We often will see radial subluxation, the first metacarpal base. And again, the usual subchondral sclerosis, osteophytes, on occasion loose bodies. Radiocarpal joint OA, almost always secondary to trauma. But we do have some other examples of infiltrative process like the metabolic arthritis, CPPD. We also can see post-traumatic carpal ischemic necrosis. Sometimes we can also see scaphoid fracture where the pole has been separated from blood supply and it undergoes necrosis. Decrease in the radiocarpal joint space. Boy, you really do have to be fairly experienced to appreciate that. But you can usually pick up on the sclerosis, and by God, if you see osteophytes, know that you're in the DJD environment. Subchondral cysts are possible. I have to say, I appreciate them more often on CT or MRI studies of the wrist, more so than plain film. Here we have a very wide gap between the scaphoid and the lunate. This is often the product of a fall, an outstretched hand. The fall will often cause the capitate to kind of split the space here, kind of like a wedge splitting wood, if you will. Prominent loss of joint spacing here, sclerosis that makes me suspect that this is actually on its way to necrosis. Here we have an ulna minus scenario, so the bulk of the joint spacing is between the radius and the carpals. This can set up an environment for increased luxation or dislocation of the lunate. We also see a little more often fracture of the scaphoid in the ulna minus environment. And sometimes the patient's wrist is so non-functional, so interfering in their daily activity that they try total replacement of the wrist. Limited function, but it's at least less pain typically than what they're dealing with before. Moving on to the hand, we've got some classic nodes, Heberding and Bouchard's nodes. Heberdings belong at the dip, Bouchard's belong at the pip or proximal interphalangeal joint. For reasons that I don't necessarily think are good, this kind of question shows up on national board with regularity. They test very well. That's probably they're the best reason to see them. And patients ask about them, so it doesn't hurt us to know things, for sure. Well, is it Bouchard's or Heberdings, or is it Heberdings, Bouchard's? Well, I would like you to hold your hand up in the air and then point to your pip, closer to the metacarpal, and then your dip, and then use the alphabet. B comes before H. So you got your hand up in the air, you identified your proximal interphalangeal joint, and you know that's where Bouchard's nodes are, change in contour. If the patient has change in contour out of the distal interphalangeal joint, well, H comes after B, so that must be a Heberding node. Now, the only thing you have to watch out for is in RA, we have something called Hagar's nodes, but HA and RA go together. So I'm giving you insight into what I had to do, memory hook-wise, to keep those three nodes separate. Now, we do tend to see osteophytosis, sclerosis, loss of joint spacing, but again, it takes a pretty experienced evaluator, but more people can see sclerosis, and everybody can appreciate osteophytes. We can also see some malalignment, particularly in the dips, kind of flexion deformities or non-reducible deformities. Here we have some examples here of disease out of the dip and the pip. We're actually going to end up, this is purported to be a DJD example, but honestly, this is better for erosive osteoarthritis, a primary form of DJD. Now, this sketch is quite good. Here's the change in contour that represents Bouchard's nodes, and then you can see the change in contour that represents Heberding's nodes. Just to review, here we have a good evidence of patellofemoral DJD. We've got reduction in joint spacing, osteophytes on both articular surfaces, prominent loss of femoral tibial joint spacing, and we have joint mice all contained within the joint capsule. So this is as good a picture of DJD as you're going to see. Same patient on the AP view. Really can appreciate the irregular contour of the patella, the lateral subluxation, the change in tibial plateau and tibial eminence, osteophyte formation, and then again, medial compartment loss mostly. And that finally is the end of the degenerative section, part 3. Now we continue with the degenerative section, part 4. We're going to focus on spine and sacrum here. So here we are taking a look at an AP lower cervical and a neutral lateral radiograph, and a lot to see. Several things. Again, if you have an organized way to approach the film, I again suggest ABCs. So we can see a quick look. The bodies are here, the set column is here, posterior turbulent spines are here. Again, work your way around each and every cortical margin, and it'll take you some time. It'll get quicker and quicker. It'll eventually take you longer to move the mouse around the image than it will actually move your eye around the image. Hopefully you pick up here, we've got the mastoid air cells, normal, and then you can see some soft tissue outline. The patient's image is good enough you can appreciate the soft tissues of their ear. This person has a posterior ponicle, or sometimes called an arcuate foramen, anterotubercle, posterior tubercle. Hopefully you'll come to easily identify the dens, even though it's bracketed on both sides by the lateral masses of C1. Usually there's enough penetration of the beam that you can make out the outline of the dens. Very, very important. And really the only really good looking joint space we have is between C2 and C3. 3 and 4, 4 and 5, 5 and 6 are all narrowed. We lost the posterior disc spacing at 6, 7, and 17.1 starting to look pretty good again. Certainly is a posterior weight bearing and flattening of the orthotic contour for sure. So we can get a good idea about joint spacing and whether discogenic spondylosis is in place. On the AP lower cervical view, the uncovertebral joints, or the uncinate joints, are sometimes called the von Luschka joints, consisting of an upturned lip and then a downturned lip, and there's a pair of these. If tube tilt was used to better effect here, and maybe had the patient's chin lifted just a little bit, we'd be able to more clearly see higher into the cervical region. So good example of what spinal DJD looks like: loss of joint spacing, subcondylar sclerosis. The subcondylar line is a little denser than normal, but again, most importantly, by the time you can make out the fact that there are indeed osteophytes, whether they're on the anterior part or the posterior part, you know that you're in the DJD scenario, since that's the only arthritis associated with osteophyte formation. Here we are looking at the same patient, and we're looking at oblique views. Again, we're intended to be able to look at one set of posterior elements at a time. You get one body, one facet complex, and kind of a look at the spinous process. And again, going up to the very top, this is the only really good intervertebral foramen or IVF they have presented. It looks good on both sides. Just one level down, you can see facet hypertrophy is intruded into the posterior part of the intervertebral foramen as it did one level lower. Here at this level, and this is 2, 3, 4, 5, 5, 6 level, we have both facet hypertrophy or facet arthrosis intruding into the intervertebral foramen, but we also have part of the Luschka complex intruding in. And remember, the nerve roots come out right below the superior pedicle in an IVF. So it's possible, at least, that this patient is demonstrating some segmental sign and symptom. Now, this does prompt me to share with you a common mistake. If we make our patient education reporter about, oh, this is bone on nerve, Mrs. Williams, but we can take care of you. And some patient will say, well, what are you going to do about moving my bone off my nerve? And the fact is, you don't do anything. And the good news is that's not really what happens. These are, on the backside, the facet joints, those are synovial joints. And of course, then we have cartilaginous joints in the disc. The joint capsule is what gets swollen, irritated, and the adjacent structures, including the nerve root, can also become secondarily involved, and that alone is sufficient to produce a segmental sign and symptom. So the good news is, as we restore mobility, joint health largely returns, the inflammatory process recedes, and that takes pressure and irritation away from the nerve, and the patient reports feeling better. We commonly take care of these conditions. It's the unusual patient with neck and arm pain that we can't help. I just suggest you tell the story correctly in the first place. That, yes, it doesn't look great, Mrs. Williams, but it really is the soft tissues we can't see. Every joint has a kind of a bag around it, keep the fluid in. It gets swollen. My treatments are going to allow those tissues to heal, become less inflamed, less swollen, and that will give the nerve the room it needs, and this will happen relatively quickly. So that's the story I would suggest that you tell your patients as you review images with them, because if you're going to do follow-up imaging a couple weeks from now, and the patient is really 100% approved as far as their neurologic complaint, you still are going to be showing them essentially identical radiographs, and that sometimes weakens the doctor-patient relationship. Now, jumping down to the lumbar spine, here we have a couple of classic presentations. So if we take a look at the L4, L5 level here, L5 is the sacrum. So again, this is off an AP lumbar view. We did not use tube tilt, so it's challenging to be able to appreciate the L5 S1 disc space. Now, this large structure off the side, you can see it's got continuous cortex. And because there's a horizontal component before it wraps around, we refer to this as a traction osteophyte. Traction osteophyte. I've got some examples of a claw-shaped osteophyte, which actually does not require disc pathology, but the traction certainly does. Now, on this view, we've got a couple things to pay attention to. One, we've got reduction in the sacral base angle. This typically on a standing patient is going to be 42 degrees plus or minus 7 degrees. So this is clearly reduced, and that can often be produced by muscle spasm. We also have gas density in this very thin L5 disc, and again, another collection of gas where the nucleus pulposus should be, and this is referred to as the vacuum phenomenon. So the vacuum phenomenon is gas collection in the space which should be occupied by the nucleus pulposus. Thorough dehydration, sometimes referred to as desiccation, are what's required to create that potential space. Then the patient does have to either go into flexion or extension, in some way increase the volume of the disc space. That reduces the pressure, and as you may or may not remember from Boyle's law, gas comes out of solution under those conditions. Well, again, of course, we can appreciate the marginal osteophytes, which again clearly indicate that this is DJD. But we also have an L4 retrolithesis. Most of the world that looks at radiographs will identify the lower vertebral body as the reference vertebra, and then we describe the relationship based on what happens above. So this is an L4, L5 retrolithesis. Now, if you are in a Gonstead class, it's perfectly acceptable for a treatment class to look at things differently. Clarence Gonstead put together a remarkable assessment and treatment technique. He worked around his very severe rheumatoid arthritis, so many of the hand contacts are all he could manage because of his underlying joint pathology. He also developed treatment techniques that were essentially delivering thrust from P to A. So they usually would reference things in a way that would allow them to record their treatments in accordance with the treatment philosophy. And that sometimes puts them at odds with the rest of the radiology world. But as long as we recognize that there is a way techniques use information, and there's a way that the rest of us use information. So for our class, this will be an L4 retrolithesis because it clearly is extending posterior. Now, if you don't like this position for some reason, all you really have to do is have the patient lean forward, and it's going to go anterior. The lack of water and lack of glycosaminoglycans molecule holding fluid in the center of the disc allows the end plates to get close together. And if you've ever driven a car on a half-inflated tire, or if you've sat on a half-inflated physio ball, you know how that feels. It's very sloppy. Well, intersegmental instability or intersegmental hypermobility is one of the consequences of a severe loss of disc height. Now, another shape, this is usually limited to like L4, L5 area. The combination of facet arthrosis and sometimes circumferential bulge of the disc or even posterior osteophytes off the vertebral body can change the shape of the central canals, usually round to oval. Here in this case, it's divided up in kind of what looks like 3 leaves, hence the name the trefoil central canal. Trefoil central canals are associated with what's known as lateral recess stenosis. Now, this is the same vertebral level. This is a CT image, fine bone. Look at the outer layers, clearly white, so we're looking at a CT. The volume we have here on this bone window versus what we see here, again, relates back to what I was saying before, that in the bone window, we can't appreciate the joint capsule. On the soft tissue window, we appreciate the joint capsule, and that's what further narrows this. And again, a patient with apparent presentation of segmental signs and symptoms and the trefoil-shaped central canal, they often respond to our adjustments because we, again, put good motion into a joint, allows good joint nutrition, inflammation and swelling can recede, and that gives just enough room for the exiting nerve root to become normal and function again. Now, we do have some patients that do acquire such a degree of lateral recess stenosis that we're not able to help them with conservative means, and they may need a more aggressive solution, and that could include surgery. So, trefoil central canal. This image, these pair of images really highlight the difference between an image that includes the soft tissues versus one that doesn't, and we can do that by manipulating the level and window in the CT image. It also is identifying the reasons for concern in the trefoil central canal because of lateral recess stenosis, and claudicoina compression is the outcropping of that. Because again, remember, the cord ends somewhere between T12 and L1 in most individuals. Now here's another look at facet arthrosis. Here we have, again, good examples of osteophytes off the vertebral body, and they really, because they're horizontal, are more likely in the category of a traction type osteophyte. Here, where the hook starts pretty much right at the joint margin, this is a claw-shaped osteophyte. It's important to note that claw-shaped, both are stress responses, no doubt, but the claw-shaped osteophyte can appear even in the presence of an intact disc. Traction osteophytes are exclusively associated with disc pathology, disc degeneration. Now, I titled this FA, or facet arthrosis. The oblique views of lumbar spine allow us to look at a single side of the facet pairs, and what we should see is relative congruency. This is the superior articulating process of L5, and the thicker white line here. This is the inferior articulating process of L4. They should match up. You can see this extends well below the density of the L5 facet. This is sometimes referred to as rostrocaudal migration. It's the logical consequence of disc space narrowing, where this end plate is going to get closer to that end plate, so these joints have to slide past each other. Again, that introduces a certain amount of slack. Intersegmental hypermobility may be seen. We certainly will increase the load on the facet complex. They're usually designed to receive somewhere between 10 and 20% of the load, but they'll start getting more load that constitutes excess wear and tear, and the DJD will progress under those circumstances. Down here at L5S1, you can see there's such a degree of joint space narrowing that the articulating facet of the sacrum is actually butting up against the pedicle lamina junction, and before too long, it'll start remodeling rather significantly. Here we have an example of, this is the same patient, just took a close-up image, and you can see that in this case, here we presumably are looking at L5, and here we have L4 in an anterior position. This is the reference vertebra, and this is the one we'll reference, so anterior lethesis of L4 versus L5. We would report this out by the percentage method, so we would measure the entire length of this end plate, and then take the pedicle body junction, drop it down perpendicular, measure this distance, and then divide the big number into the small number, and we'll get the percentage. I would estimate this to be about 15% anterior lethesis. Now, Wilsey has produced a very useful classification scheme for spondylolisthesis generally, and this is referred to as a Wilsey type 3. It's the result of facet arthrosis or facet DJD, and in years past was referred to as pseudo-spondylolisthesis. I would have been happy with pseudo-spondylolysis because it does imitate a spondylolytic segment, but there's actually nothing false about this anterior position. It really is too far forward. Facet arthrosis and the resulting remodeling of the facet complex can produce about a 25% anterior lethesis, so rather significant. So again, out of the Wilsey classification system, which I think you should know, this is considered to be a type 3 and represents the result of degeneration or DJD involving the facet complex. Name the study. So let's give you just a couple seconds to take a look at it. And hopefully you've identified where you are. Here's a right ilium and a left ilium. That makes this bigger structure here, the sacrum. And now we've got the posterior elements of L5 as we look at the L5S1 facet complex. Now this is the thecal sac, and ordinarily this would be a black or maybe slightly gray density because it's fluid filled, so it's going to look more like this area here. But when you introduce a suspended metal, like we would for a myelogram, we would now increase the density of the contents of the dural sleeve. Here, these are nerve roots. Right here, this little black dot is actually a nerve root ready to go out through a sacral foramen. It's surrounded by a nerve root sleeve, which is filled with contrast. Now notice how sharp and clear this nerve root is compared to this one. Well, this is what neuritis looks like on a CT myelogram. And again, this is a bone window, and you can see great bone detail. You know it's a bone window. And even though we have contact here, it really isn't enough ordinarily to cause trouble. But when you factor in the soft tissues that encase this joint filled with fluid, and if this is the result of facet syndrome, they can often get segmental signs and symptoms in the lower extremity. Again, this is a patient that I would not hesitate to offer my services. My expectation would be a good response because there really is plenty of room in the lateral recess. We haven't closed down the central canal into the trefoil shape, so I would expect the patient to really recover quite nicely. And as long as I keep them moving, then things should go well for them. So again, we'd like to know that the CT myelogram, why is it important? This is considered to be the most sensitive test for central canal stenosis, where sensitivity indicates the incidence of true positives. And then I also wanted you to see what a normal nerve root encased by the nerve root sleeve looks like versus an inflamed edematous one that is almost certainly producing symptoms. This is the kind of patient that comes to a chiropractor. You know, they are offered either not getting relief anywhere else, or they've been told that their only path to resolution is surgical stabilization, and they may have reasons, fear, health, money, for not wanting to pursue that. Believe it or not, we can take pretty good care of these patients. Now, it's not a couple of adjustments that are good for life. This is the kind of patient that often benefits with a regular schedule of care. Now, there are some orthos and VCs that would like to straighten out this spine. But I'm telling you, that is not a reasonable therapeutic goal, because this patient's scoliosis has been in place long enough that the height of this side of the vertebral body, where it's been compressed, versus the height of this vertebral body, where it's been unloaded, is not the same. Down here in L4, you can really visualize it's shorter on the compressed side, the concave side, and it's taller on the convex side. Hooter and Volkman and Julius Wolff tell us that when you compress a growing vertebra, you can inhibit its growth by up to 10%. If you unload a vertebra, it can overgrow by up to 10%. So you end up having a bunch of uneven blocks to build, and you just can't build anything straight out of that. But we can help the joints move safely. We can help guide them towards activities that will be less stressful. We can offer them a essentially maintenance program that will keep them very functional. That's absolutely what we can do for these patients. Here again is another picture. Now we got two things going on. We have anterothesis of L5 versus S1, and then you can't make it out. I would never really ask you anything about this, but since we see the end plate so well, there's an additional anterothesis of L4 versus L5. Now, I don't see any evidence of lysis, but I would want you to know that the most common cause for anterothesis at L5 is spondylolysis, or bilateral pars defect. The most common reason for anterothesis at L4 is spinocerebrosis. Now, for this patient, because we can see the pars area is intact, we are truly looking at simply a severe case of spinocerebrosis, and that's producing the Wilsey type 3 anterothesis. We also have a collection of gas. We know this is gas, sometimes referred to as pre-atmospheric methane. We have gas density here in the disc, and it could be the lucky overlay of bowel gas, but on the CT image, we can see clearly the gas is collected and superimposed on the vertebral body, telling us that this is a great example of vacuum phenomena, where gas is able to collect where the nucleus pulposus should be, and this is the result of thorough dehydration bordering on desiccation of the nucleus pulposus. I mentioned vacuum phenomena a couple of times. I should tell you that there is also something known as vacuum cleft. Vacuum cleft is a much smaller breach. It's ruptured annular fibers, usually at the periphery of the disc complex. So, and most often evident along the anterior portion, whether it's the anterior superior quarter or anterior inferior quarter of the vertebral body. Again, it's a potential space. When the volume increases, gas can come out of solution, and it'll give us a little gas density right at the edge of the disc space. Here we are again looking, now in this case, we're looking at an MR image. Fine bone, go to the outer layer, and if it's black, know it's dense. Dense bone will not signal an MR, whether it's under T1 or T2 or any hybrid conditions. For this patient, we see they've got decent hydration in the L2, L3, and L4 disc. Get down to the L5 disc, quite displaced. The nuclear material is extending past the breach in the annular fibers, and it's possible that it's producing dural effacement, so the dural sleeve is being irritated. And every once in a while, it can also attract or come in contact with a nerve root about to exit, and again, produce segmental signs and symptoms. You can see how it's really in a posterolateral position, just off midline, and here's the next rootlet to exit. We don't really see it over here. So this would be consistent with a right-sided neurologic complaint. Extrusion or prolapse would be another word. Here's just another example. In this case, it looks like it's separated from the parent nucleus, making sure that it's likely that it's sequestered. And for this patient, if we can keep their pain under control for about 2 months, as we talked about in an earlier session, we should expect phagocytosis to lead to complete resolution. The fact that it became sequestered, and I really think that's what much of our chiropractic adjustments do, is create opportunity for it to become sequestered, separated from the parent nucleus. It will undergo a form of death, and that will start the chemical signaling that there's an invader here. Now, this is still in the realm of just simple discogenic spondylosis, DJD, of the spine, but there's a variant pattern of presentation. It's relatively common. This is referred to, and I love the name because it's so descriptive, hemispherical spondylosclerosis. So we have a half circle of density within the vertebral body. There's two importance attached to this for me. One is just that don't overemphasize this. This is just simply DJD. Absolutely, this patient's going to respond to your care. But in the tumor section, I have a case of blastic metastasis where only one vertebral body has this half circle of density, and there's no companion density below. We have to appreciate that in an arthritis scenario, we expect both end plates, above and below the disc space, to be involved. And because that half circle of white was only in one vertebral body, it was easy to suspect blastic mets, and we very quickly got to the correct diagnosis. This is the same patient, AP view, and again, you can see the horizontal presentation of the osteophyte, making it a traction-type osteophyte. And as is common in many patients of this generation, we see conduit-type calcification, as we see atherosclerosis involving the abdominal aorta. Now, think back to our modic changes, if you would. Remember the modic type 3. We see that because dense bone will reduce the signal on T1 and reduce the signal on T2 images. So if we were to take this patient to MR, we would confidently predict that we'd be seeing modic type 3 changes as we reviewed that MR study. But density, that's just how it behaves on MR images. There's a case that came across my view back many years ago. There had to be a student sitting reviewing films with me. And in class, we just gone over bone metastasis. So here we've got this dense region. It is by an SI joint, but as you know, it's kind of ear-shaped, auricular, at an angle. So I really can't tell in a single view whether we're dealing with an osteophyte or whether it's a dense bone region. So, of course, you lean in, you take a closer look, and we still can't decide, is this superposed or what? Well, fortunately, oblique views came, and that allowed us to see that this was a continuous cortex with the sacrum in this case. So now we were able to confidently identify this as an osteophyte, simple sacroiliac DJD, and didn't need to do anything other than report that. We find the best evidence for SI DJD usually along the inferior portion of the joint. We got this bone projection here. That is what the osteophytes on sacrum can look like. Even down at the sacrococcygeal joint, we can at times have arthritis develop, can be quite uncomfortable, does usually respond to treatment. And that's just another example of what the sacrococcygeal DJD can look like. On our, again, what image studying are we looking at? Let's take a quick look. Hopefully you identified this as the sacrum, and then went to the outer layer. See that you can demonstrate cortex is white, so it has to be a CT. Definitely have osteophytes on both sides, the sacral side and the iliac side. But when it comes to subchondral sclerosis, it's usually concentrated on the iliac side. And for years, we noted that we couldn't explain it. Now we can. A couple of research projects have just identified that the sacrum is inherently denser. Well, why? Well, think about it. All the weight of the spine comes down onto the single sacral promontory. But then the sacrum will send half the weight down the right ilium and the other half more or less down the left ilium. So when load characteristics change, the ilium has to change more than the sacrum does. That's been a useful explanation. Now, kind of finishing out this area of degenerative change, I would like to talk about calcific tendinitis and bursitis. It's often lumped in with degenerative change, particularly in the post-traumatic secondary DJD setting. We will return to this topic after midterm when we talk about the metabolic. Actually, we'll get to crystal deposition diseases in the metabolic section. We'll talk about HAD, hydroxyapatite deposition disease. So I did want to give us some good examples of calcific tendinitis. The shoulder complex is a particularly rich area for this kind of problem. It usually starts out as a tendinitis, and then it can convert to a tendinosis, and then finally end up with calcification, precipitation within the injured tissue. In the shoulder complex, and really throughout the body, the most common location is in the supraspinatus tendon. When you think about how involved it gets in case of impingement syndrome, how small the space it has to pass through to insert on the greater tubercle, it really is uniquely positioned to get injured. We also know that there's about a 1 centimeter length in the tendon that's poorly vascularized. That makes it very difficult to defend itself and repair itself, so it ends up being a high yield area for sure. Subacromial bursa is another site for dystrophic calcification, but truly any of the rotator cuff can become involved. So here we got two different but classic examples of, again, what's likely hydroxyapatite deposited just short of the insertion in the tendon of the supraspinatus muscle. It's the result of repeated episodes of injury leading to, again, dystrophic calcification. I link the D in dystrophic with D in damage, so it's not normal tissue at all. One thing we want to make note of, if we do find calcification within a tendon or bursal tissue, we do need to treat it, and it can be conservatively treated, and there's numerous ways to do that. Sometimes using lithotripsy, ultrasound, iontophoresis, there's a range of treatments, and the benefit of the treatment is we avoid the most serious complication of calcific tendinitis, which is spontaneous rupture. Now, it doesn't tend to just pop while you're sitting there, a patient sleeping or something. You have to do something, but it's pretty innocuous. It could be as simple as reaching to put away a coffee cup in a cabinet. I mean, it's definitely in the trivial trauma category, but we do refer to those events as spontaneous rupture events, and it is by far the most serious complication of any calcific tendinitis. Before I end this section, I do want to tell two research projects. I'll paraphrase them, but they had a big impact on how I looked at things. And that was many years ago. So one study I refer to as the couch potato story. And the couch potato, of course, is somebody who sits around, consumes lots of TV. They don't really have any physical activity in their life. They really only have one well-developed muscle, and that's the opponent's pollicis of whichever hand they hold their TV remote in. Sometimes engage in a little abduction of the upper extremities. They open a new bag of Doritos or something like that. But you get the idea. When we compare the rates of new diagnosis of DJD and progressive DJD against the people who are just completely active, they're hiking, biking, strolling, they're learning new activities all the time. And this research group predicted that it was going to be the very active group that was going to have more DJD. And the thought process was, well, it's purely a wear and tear phenomenon. And boy, were they surprised at the end of their multi-year, several thousand subject study, where actually the highest rates of new DJD were in the couch potato group. And the most progression of DJD was seen in the couch potato group. Why? Well, Guyton's textbook on physiology tells us you feed a joint by movement. So when you're sitting around, you're gelling. And in that gelling environment, you're not getting good exchange of nutrient and removal of waste products. So now we know that there is something other than wear and tear. So that study had been laying out there for a while, and it certainly was useful to me to encourage safe level of activity, to speak against sedentary lifestyles and so on. And then I came across an animal study. I call it the old rat, young rat study. And what we had was they took a cohort of rats. They let them live their life out until they were all in the geriatric rat age group. Then they brought in 60 new young rats, divided them into two groups of 30, the experimental group and the control group. What they did was they withdrew synovial fluid from the hip of all the old rats and would put a small amount of that into the experimental group of young rats. And then every day they would take an experimental rat and a control rat, euthanize them, disarticulate the hip, fix it in paraffin, thin section it, stain it, and then look at the joint features. And first day the joints looked identical, second day a little less identical. By the end of 2 weeks, it was clear that the experimental rat hip joint space was narrowing. The articular cartilage was thinning. At the end of an additional week, the very beginnings of osteophyte formation was being seen in the experimental rat hip. At the end of 30 days, when they took the last experimental rat and the last control rat, there were remarkable differences. The experimental rat decreased joint space, subchondral sclerosis, and osteophyte formation, while the control rat hip number 30 looked pretty much like the control rat number 1. They asked some of their research students to put the experimental rat hip slides in order, and they could largely do it with just minimal a day switched here and there. But it was very easy to pick out the most affected and the least affected, and that established their number 1 and number 30 rat. So that tells me that we've got more than wear and tear going on. It's still viable, still explains much of DJD in the secondary group particularly, but we also know that there's histochemical forces. And then go back and take a look at where I described the NMP-TIMP balances, the cytokine cascades, the ability to activate chondrocytes. All that rolls in as part of the theme, the larger theme of DJD. So that concludes part 4. Thank you for your attention. All right, degenerative part 5. Now we're going to turn away from degenerative joint disease and start looking at some of the other members of the subcategory of arthritis we refer to as degenerative. So we're going to take a look at really quite a common arthrotype, DISH for short, diffuse idiopathic skeletal hyperostosis. So just parse the name out just a little bit. Hyperostosis, what we'll see is thickened tissue, ligaments, attachments, parts of soft tissue attachments at joint complexes involving any part of the skeleton. We're going to be focusing on the spine, but there are certainly other non-spinal sites. Idiopathic, while we certainly have learned things about DISH over the years, we still don't have complete understanding of who gets it, why they get it, and so on. Diffuse just refers to the widespread presentation. Spine, calcaneus, costal transverse joints, inferior parts of SI joints. Again, fairly wide distribution of this really typically benign process. Here's two great examples. This is my best example of anterior longitudinal ligament hypertrophy as part of DISH. And make note of, look at how this spacing looks pretty good. Now down here, this is an example where we have DISH on the front side, and independent, still present, is a posterior osteophyte. So this level, we could argue, has both EJD, but predominantly we're looking at the DISH. Now, this comes with the most common chief complaint, this cervical presentation. That's dysphagia, difficulty swallowing. You can get an idea how far interior the pharyngeal air shadow is being pushed. And then remember, the pharynx empties into the potential tube of the esophagus down by C5. And again, there's some significant posterior anterior push on the epiglottis, and that makes it challenging. And a difficulty swallowing or dysphagia is the by far most common chief complaint. That's really one of the common reasons we go looking for the explanation. This image over here, not a great radiograph, but it's the father of one of our graduates. It was during a GIGU class where we were talking about dysphagia. The student came up after class and said, my dad has this difficulty swallowing, and but his doctor says there's nothing wrong. So we talked a little bit further, and he had complained to his primary care physician. The physician ordered a esophoscope. So he got chemically twilighted. They put the camera in the mouth, pharynx, traced it through the esophagus all the way down into the stomach, and didn't see any problem. Well, you're only looking at the inside of a tube, and you don't notice if your instrument gets translated anterior, like they would have to get around the very thick ALL right at the uppermost portion of the esophagus. So it was after we talked, I recommended that, do you have a chiropractor? Yes. Does he have an X-ray machine? Yes. Ask him to do a 3D cervical, and this is the result. And now we know that her father's dysphagia complaint was the result of hypertrophy of the anterior longitudinal ligament. What do we do? Well, in the past, they would have tried surgery, but it turns out it grows back bigger and thicker. They tried radiation therapy, and of course, ligaments don't have very high metabolic rates of activity. So what happened more often was either leukemia or lymphoma. So they thankfully stopped doing that. They tried some chemotherapy drugs, and of course, they're cytotoxic, and again, kind of depend on metabolic activity. So the patient got very sick with no discernible effect on the ALL. Now we know what we tell the patient to do is just cut your food smaller, chew it thoroughly, and have some drink available to wash it down if you have to. It really is a management problem, not something that needs to be cured. Now, next I'll be showing you a series of images that I got from Scott Air Force Base. Actually, a patient I had rotated out of the service, stayed in the area, was seeing one of our referring clients, and the referring client could get the images but not the reports from the military. So asked us to generate reports on these. And, on the one hand, today, using guidelines, we would never have seen this series of films. But in the military system, as was described to me, more or less once an order gets placed, you keep the same order, and the order just keeps repeating itself. Now it's going to end up being to our benefit. This is the earliest radiograph, and it was part of a chest film. And concern was raised with regard to what was interpreted at the time as a large solitary pulmonary nodule. Subsequent exams yielded that it was not an issue. Comes back, and I actually have filmed every year, 88, 89, 90, the annual event. I just skipped years to still carry the story. 2 years later, we see what's really going on is very thick, flowing, exuberant ossification, sometimes referred to as undulating pattern of ALL thickening. That clearly is a good start on DISH. I say good start because the principal researcher, Forstier, he did a great job identifying the characteristics, the distribution, but claimed to require 4 contiguous segments. Well, clearly here, at this stage, looks like he's only got 2 vertebrae, and this is going to be interpreted as DJD, DJD. Now, in the thoracic spine, where we clearly are, as you see the ribs coursing across, this is actually pretty good disc spacing for thoracic vertebra. But again, Forstier set the rule. He was the first to discover it. He got to set the rule. Now, here we are jumping forward to 1994. And again, relatively unchanged over time is the original undulating ossification of the ALL. But now we see what was first interpreted as osteophytes actually end up being more ALL thickening. And notice the disc space hasn't changed. And now we're beginning to get suspicious about this level. So at this point, we've got 1, 2, 3 levels. We're close to satisfying Forstier, but not quite. Go forward 1 year, and now we see, we've got the beginnings of ALL thickening down here. Here's the original. We've got more, and then now we can resolve that we've got 1, 2, 3, 4, and developing a 5th level. So everyone's happy now. Again, 1 year later. Again, 1, 2, 3, 4, 5. Now we've added a 6th level. And T7 through T11 is, it turns out, the most common levels for DISH. And you can get an idea, it took from 1996 is the last image I had. We started in 1988. So over an 8-year period, it progressed through these stages. Now, my point here, when you take a look at the study guide I put together, which includes perivertebral ossification patterns out of Chapman and Kelly's very useful handbook, Aids to Radiological Interpretation. They've got patterns where they identify the claw-shaped osteophyte. They sketch for us what the traction osteophyte looks like. We've seen examples of that in prior presentations. This is the standalone undulating pattern, or I say flowing exuberant ossification, and the only thing that produces this is, of course, DISH. So if it's DISH in 96, I back up. This is not an osteophyte of either kind. It's not pencil thin. It's not C-shaped stuck on common non-marginal, which is a pattern typical of psoriasis and reactive arthritis. It can only be DISH. So I call it DISH. Until Forstier contacts me to complain, I'm going to keep doing it, and I suggest you do the same. Now, some fun facts about DISH. While we still don't understand why it develops, we have no ability to predict who will get it really. We do know, again, that the most common symptom of cervical presentation of DISH is dysphagia with a G, GI tract dysphagia. We also know there's a common comorbidity, and that's diabetes mellitus. The studies I've read range from 13 to 40% of patients with DISH also have diabetes mellitus. That's too high to be simple coincidence. Now, early experts claimed to notice that about half of dish patients will also have ossification of the posterior longitudinal ligament. That requires us to look into the central canal in every case of suspected dish. I will tell you I see dish very regularly, but only rarely can identify OPLL. As a single group, Japanese men appear to be the most common group to present with ossification of the posterior longitudinal ligament. There's some more recent evidence that use of retinoids increase the risk of dish. And there's been information that I don't really quite know what to do with, but societal affluence. So richer people tend to get dish more so than poorer people. That to me implies that there is some choice. There's something that we're choosing to do that produces this, but there's been no further authoritative research, but still interesting to note. As I pointed out, the disc space is certainly not required to be narrowed as a part of dish. When I see disc space narrowing, I actually tend to look for degenerative change to identify as DJD. And the range of motion that a patient with dish has will always exceed what you would predict based on the radiograph. In fact, the patient will possess the majority of their original range of motion. Treating these patients, adjusting them, I will say there's a little kind of sluggishness. You don't get the same crisp cavitation, but they certainly can be treated. They respond well, not even all that much slower than your typical non-dish patient. But jumping ahead, we're going to be taking a look at, in the inflammatory group, something known as ankylosing spondylitis. That produces true syndesmophytes, and they're very thin joint margin bits of ossification, ossified outer annular ligament, actually. Well, they're very rigid. They live up to their name. So that very thin paravertebral ossification produces true fixation, immobility, and ankylosis. You got this very thick and flowing ALL seen in dish patients, reduces range of motion, but not significantly. Here again, this is an example of a patient with easily recognizable ALL thickening, but hopefully equally recognized PLL thickening. It was likely some combination of the patient's dysphagia or long tract signs in the central canal. Unfortunately for this patient, this is a surgical requirement. There's no conservative care, no treatment that will resolve this. And the goal of the treatment will be to increase the size of the central canal. Here again is a CT image showing again the ALL thickening as well as the PLL thickening. And you can get an idea how narrow the central canal is. So multiple levels of decompressive surgery are required to manage this patient effectively. Here's the same patient on an MR image. And again, this is dense tissue. Dense tissue also will show there's a signal void. More importantly, we can see that it's actually changing the contour of the cord. This explains the patient's long tract signs. Now, why did their pain start after a fall? Well, this grows fairly slowly. You saw it took 8 years to go from a single motion unit to several motion units on that thoracic study we looked at. And the nervous system is plastic, so there was a certain amount of rewiring, if you will, changing communication responsibility. Finally gets to the point where the nervous system can't adapt anymore, and this fall just may have been the triggering event. Here we are taking a look in the thoracic region, and this is very obvious, very thick flowing ossification of ALL. This can only be dish. Over on this side, this is a little harder. This does somewhat look the way ankylosing spondylitis would. Now, big key difference is going to be that this patient's motion is better than the Angst-Spon patient. And since we have a couple of spots where it's really too thick to be thin, that helps, but that will take a rather close inspection and an astute observer. Another lab study would be helpful, is that ankylosing spondylitis is strongly associated with HLA-B27, and dish is only softly associated, infrequently associated with HLA-B8. So we really don't have any useful lab findings for our dish patient. So obvious case here, less obvious case here, but since we have a couple of spots that just exceed the thickness of Angst-Spon, then we can be confident we're dealing with dish rather than AS. Now, one of the variant presentations of dish is this finding here on the anterior superior corner of L4. This is referred to as the flame-shaped syndesmophyte by some, or I actually prefer the flame-shaped paravertebral ossification. I like syndesmophytes to be defined as ossified outer annular fibers, and this is more than that. There's a 3-item differential for the flame-shaped paravertebral ossification, dish, as you imagine, but also reactive arthritis, formerly known as Reuters, and psoriatic arthritis. Well, the good news is these two things come with signs and symptoms. These patients all have skin disease. These patients, we have some part of the clinical triad of conjunctivitis, urethritis, and polyarticular arthritis, and a history of sexually transmitted disease. So if you find any of those things in this here, then you know you're dealing with one of them or the other of them. Dish doesn't really have any companion disease, except maybe diabetes, but that's still 13 to 40% better inclusion criteria rather than exclusion. So really what we do with this differential is do what we can to rule out reactive and psoriatic, and then if we do that successfully, be confident that we're dealing with dish. Here we have again, take a look at bone, find the outer layer, looking at CT, looking at the central canal. Now this would tell me that, oh, here's the cord. Cord lives right behind the vertebral body. Well, then we go to soft tissue window. I need to ask you, well, what is this right here? That gray, now bean-shaped thing. This is the cord. This is ossification of posterior longitudinal ligament, and you can see it's clearly displacing and compressing the cord. And again, this patient will require decompressive surgery. Here's a smaller example, very central overgrowth of the ALL, dimpling or indenting the center of the cord, making kind of a heart-shaped presentation. Here's a nice Valentine's Day shaped cord, I guess. Now, while we still can't explain all patients, we have learned a few things. We do suspect that there is a genetic component to this, and based on some of the other peripheral research, environmental factors we see, like the affluence in the society or the use of retinoids and so on. We do know that some of the genetic information has led us to understand that the baseline population is 1.9 to 4.3% of Japanese, and again, largely men, will demonstrate OPLL, where when we take a look at men and women in Europe, 0.1 to 1.7%, rather small. And then we do see gender bias, about 2 to 1 males to females, and age bias, as we typically are looking at people over the age of 50. So again, we don't fully understand the etiology, so DISH needs to keep the I in the acronym, but again, we've learned a few things of note. Now here's a patient that it could be long tract signs that sent the patient in for imaging, but also could have been immobility at C2, C3, failure to respond to treatment, so persistent immobility. Well, this is one of those patients that has two problems. One, they've got the congenital anomaly of a block vertebra uniting C2 and C3, but much more importantly, they've got ossification of the posterior longitudinal ligament. This is the kind of pattern that you would want to sit up and ask, is this a Japanese male? Because the odds would suggest that that's most likely. Take the same patient over to MRI, and again, you can see the undulating pattern. It'll be a low signal, but here compression the cord. We can see this change within the cord. These are flow artifacts and signs of impending, if not frank, damage to the cord. Again, another CT study showing the combination of ALL thickening and PLL thickening, a cross-sectional CT, giving us some idea how much room it's actually taking up. Another larger example, a little ALL thickening, mostly PLL thickening, and again, you can see how much of the central canal is occupied by that enlarged and thickened ossified ligament. Of the many surgical procedures, this is the one that if I was involved with this is what I would recommend. Essentially, the surgeon would come in and do a bilateral break in the lamina, but then they would hinge open and use a spacer, put some pre-bone or bone matrix in here, secure it across the acquired fracture, and what you end up doing is changing the volume of the central canal from inside the dotted line area all the way to the back. That will allow posterior migration of the cord and usually relieve the compressive pressure. This is what the intraoperative picture. These are usually multiple level procedures, and again, this has a very good result and preserves a lot of motion, preserves a lot of motor control of the cervical spine. Here's some things I've been done in the past here. They completely removed several vertebral bodies, put this artificial spacer and anchored it above and below the spacer. Very aggressive surgery, as you can imagine. This is all the same patient. And that concludes the degenerative section, part 5. Now we're going to talk about the sixth and final lecture attached to the degenerative subcategory of arthritis. First, we're going to take a look at erosive osteoarthritis, sometimes referred to as inflammatory osteoarthritis or primary osteoarthritis. This is considered to be still a degenerative entity, but it definitely has an RA-like presentation. Yet, it's typically seronegative, meaning no rheumatoid factor. We often present with, the patient will present with bilateral soft tissue swelling, and that certainly is part of the thing that confuses patients and physicians alike. And the swelling appears to be symmetrical. So if it's second, third digit on the right hand, it tends to be second, third digit on the left hand. Now, arthritis that fall into this erosive osteoarthritis group, or EOA for short, there is a range of pathology seen. Sometimes we do see synovial proliferation, which is very much a hallmark feature of rheumatoid arthritis, but we also can see changes that are very consistent with cartilage degeneration, as you find in DJD. There's even some cases where there's marginal osteophytes, again, another very DJD thing. Again, blood work, negative rheumatoid factor. That puts a big hole in any thoughts of a rheumatoid arthritis diagnosis. Dr. Crane was the first one to identify this as a separate entity in 1961, so it's been around longer than we've seen it as a separate entity. Now, when we take a look at clinical features again, episodic and acute inflammation. So there's pain, and pain is what drives the patients to work up and subsequent diagnosis. Now, if they're on the phone making an appointment and your staff member said, what would you like to see the doctor about? Oh, both my hands hurt. And if that's the message transmitted to you, you're going to be in a bilateral mindset. And since you've done your poster child thinking, that's going to at least make you consider the inflammatory group where RA is the poster child. Now, when they come in your office and sit across from you, very quickly recognize that the proximal interphalangeal joints and more likely the distal interphalangeal joints are the target joints. And those are definitely, particularly the dips, not RA target joints. Otherwise, demonstrate pain. You'll recognize some swelling caused by edema, often some redness, maybe even presentation of nodules, and certain reluctance, if not frank, restricted motion. Also in this EOA category is a less common finding, but still considered classic, and that's the first metacarpal carpal joint, so essentially the base of the thumb. Middle-aged females are the typical target group, usually presenting somewhere between age 40 and 50 years of age. And again, the laboratory findings, there's really nothing to speak of. No elevation of ESR, sometimes slight elevation of ESR, but it's hard to know if that's what we blame it on, and again, negative rheumatoid factor. Some researchers feel as though they've identified at least a loose familial connection, kind of speaking to a genetic underpinning. Pathologists have identified chondroitin sulfate as a common missing component in articular cartilage. Chondroitin sulfate produces the cross linkages in articular cartilage and kind of keeps the system together as a functioning unit. And as a kind of interesting side note, some of these patients have been followed for years, and it turns out 15% of patients identified initially with EOA progressed to RA about 12 years after the first presentation. It's still confusing. It hasn't been adequately explained. Some authors think that we have more work to do separating RA from EOA, but for us, we're going to focus on the degenerative features more so than the cases that progress to RA. This is when we talk about radiographic features, this sketch right here is hopefully a reminder of one of the most common presenting features on the radiograph. One, it's an ideal joint to demonstrate because we're looking at obviously the distal interphalangeal joint, and the central erosions that change the contour of these articular surfaces combine to produce what's called the gull-wing deformity. It is a non-uniform loss of joint space. It does tend to present bilaterally and often symmetrically, and there's typically some sclerosis as you'd expect in a degenerative arthrotype. Every once in a while we see what have to be considered to be osteophytes. And then of course deformities, fixed flexion deformities often present. Ankylosis can happen, but it's considered rare, and I wouldn't want that to be a dominant thought for you. But again, radiographically, what I'll be asking you to take a look for is this very characteristic change in joint presentation, gull-wing deformity, and strongly associated with erosive osteoarthritis. Here's a fairly good example. Again, you can see that middle dip here and some rise. Maybe we're looking at an osteophyte out here. Interesting to note that while the dip is so thoroughly involved, the proximal interphalangeal joint looks pretty good. Same is true over here. We're just beginning. This is an earlier step of gull-wing deformity. Same here. But the pips look pretty good on this radiograph. This is a little less common presentation. We have clear evidence of dip and pip disease. And again, central erosions producing the gull-wing and deformity presentation is of great interest to us. Move this down so you can take a look at this joint over here. Some more examples of EOA. Here again, we've got concentration of dip disease, and it's both fingers on the right hand demonstrating its more symmetrical pattern. And then a whole hand PA view, and we've got PIP disease over here, I'm sorry, tip disease over here and here, PIP disease here, and nothing down here. So again, this is a very consistent pattern with erosive osteoarthritis. Now, less common but classic, as I mentioned, is the base of the thumb. So this is a case that came across my view box some years ago, and it really represents the level of DJD made me worry about some more aggressive destructive processes, maybe even a variant presentation of neurotrophic joint disease, which can be fairly destructive. So in consultation with the referring physician, I was pretty quickly recognized this is a stay-at-home mom. Her most manual activity is actually knitting, not something I would consider to be a very physically demanding operation. So what I asked the doc to do is shoot the other hand, and sure enough, not as bad, but similar appearance of loss of joint spacing and the beginnings of osteophyte formation. So now we have a bilateral presentation. This side is a little farther along. We can take a closer look here and again and see the degenerative change. So the way I take a look at this now is that this has features of degenerative joint disease, but it really is in the wrong patient and the wrong distribution. When, as you remember, DJD, wherever it strikes, tends to be monoarticular or at least asymmetric. And when I see this as a result of DJD, it's usually in like a pipe fitter, a jackhammer operator, some really heavy-duty manual labor, and this was definitely not this patient's condition or circumstance. So now we know to put this in the primary category, there is some age relation to this, but also we have to recognize that abnormal cartilage construction is one of the common root causes. Again, the missing conjoined sulfate. Again, just a different patient now, again, kind of a DJD-looking appearance at the thumb, but then we note that it's a bilateral presentation, and the history doesn't really match. So EOA was our final diagnosis. Still in our degenerative category here, we're looking at an interesting finding referred to as osteitis cadensans iliae. As we take a look down here on the plane film, you can see there's some obvious density immediately adjacent to the right left sacroiliac joints. This is in a female patient. And we believe that essentially we're seeing the results of mechanical stress across the SI joint. We've got the anterior and posterior interosseous ligaments as well as the intraosseous ligaments hold the SI joint together. By far, the most common history is multiparity. Multiple full-term pregnancies is the most common presenting part of a patient's history. We think that the hormone changes that result in the third trimester of pregnancy persist for a period of time in a postpartum setting. Often we'll see these women have 2, 3, 4 children and a rather compact age group. So the thinking is their hormone level, particularly relaxin and elastase, never really get back down to baseline again. So they have this kind of persistent ligamentous laxity. I've seen ratios of men to women from as few as 10 to 1 to as many as 25 to 1. And I tell you, I have a really hard time identifying what causes this in a man. I've only seen one case of osteitis cadensans iliae in a male patient in over 30 years. And a good friend of mine, John Taylor, radiologist in New York, interviewed the patient, and even after extensive interview was unable to come up with a reasonable explanation for the pathomechanics that led to that change, but it was as clear and obvious as can be. So osteitis, increased bone density, cadensans, that's what we're transmitting here. Iliae is the target bone. Now here's again, fine bone. Look at the outer layer. You can see the cortex is white, so you know you're looking at a CT image. And notice that the density is concentrated on the iliac side, very typical of an OCI presentation. Here's another example, very broad-based, very dense, roughly triangular shape of density involving the iliac side of the SI joint. Overlying bowel gas makes this a little more difficult to appreciate, but again, very dense. And if you get even a little good with your ABCs and do take that look inside of every bone, you couldn't help but notice how big this area, how dense this tissue is. Now remember, on an MR image, you can find bone, go to the outer layer, see how dense it is here. So this has to be an MR image. And look at this signal void, again, on the iliac side of the SI joint. Again, dense bone of any kind, when taken to MRI, will result in a reduced signal intensity. More about OCI. Again, women 20 to 40, sometimes referred to simply as childbearing years, considered to be an incidental finding. Over the years, pain has been associated with this presentation, but then too many women had that exact same pain presentation and no evidence of OCI. So I personally don't attribute much in the way of pain explanation to conditions of OCI. We do believe it's the result of hormone-induced ligamentous laxity. The two hormones that are most often indicted are relaxin and elastase, and we think that that resulting ligamentous laxity increases the stresses placed across the SI joint, and the ilium needs to react more than the sacrum. If you remember from earlier presentations, we know that the sacrum has an inherently denser trabecular bundle. It's designed to receive all the weight from above and then distribute roughly half the weight to right and then left ilium. So when stresses change, it turns out the ilium has to make more change. We overall consider OCI to be self-limiting. It's expected that in some number of years, it varies from woman to woman, we'll be able to radiograph their pelvis and see no evidence of OCI remaining. And again, the persistent presentation of negative lab results. Now we're going to take a look at neurotrophic joint disease. And as you parse the name, you recognize that altered neurologic function is going to be the core to this presentation. So altered neurologic status arising from really a wide range of findings, congenital, iatrogenic, and acquired cases. Simply put, altered proprioception, so joint surfaces don't know where they are in relationship to each other. They literally collide. And we also know that reduced sensation will prevent the patient from fully appreciating the pathologic changes taking place. We've got three main causes: diabetes mellitus, syringomyelia, and tertiary syphilis, or sometimes called tabes dorsalis. The first of many years after neurotrophic joint disease was identified, the tertiary syphilis patient was the most common. Now, diabetes mellitus patients occupy firmly the first position, where we see 35 to 50% of patients with diabetes mellitus get neurotrophic joint disease. That's a startlingly high number. Syringomyelia results most often from post-cervical trauma, and also cervical spine surgeries can produce a collection of CSF within the cord called a syrinx. Up to 25% of patients with a syrinx will develop syringomyelia. And then tertiary syphilis, up to 20% of patients with syphilis, and this is usually in the socioeconomically deprived individuals or medically underserved individuals. We actually do have treatments that would prevent a patient moving into this tertiary stage. I've had a talk lately about alcoholism and its relationship to neurotrophic joint disease. It's not particularly common, but it's not zero, and it's definitely something we need to pay attention to. Neurotrophic joint disease comes in two major flavors. The hypertrophic form, would strongly suggest that you develop a technique to remember the 6 Ds. I've done it by kind of remembering a story, and I'll share that with you when I have a representative image up there. And then the atrophic form, candy-like appearance, surgically amputated view. Those are the kind of catchphrases that you'll see. For the hypertrophic patient, bag of bones is one of the more common designations. Here we have a classic example of a hypertrophic form of neurotrophic joint disease. So as you take a look on the lateral view, you know this has to be the talus right below the tibia. You know this has to be what's left of the calcaneus. You kind of can see the cuneiforms stacked up on each other, the cuboid sticking out the bottom. So this is what's left of the navicular. So I start with the observation. I certainly see destruction here. And then I've got evidence of debris. There is so much destruction and debris that I find this to be rather disorganized. I also see some areas where there's significant increase in density, which is kind of typical of bone death, really. This patient, believe it or not, could walk in on this foot because of the reduced sensation. And if you were to hold this foot in your hand, it would be all kinds of crunchy and very mobile. So dislocation is part of the presentation. So we've got destruction producing debris, certainly disorganization, density increase, dislocation, and then out here, this is the joint capsule. Joint distension is also part of the picture. So here we have destruction, debris, disorganization, dislocation, distension, and density. If you can figure out a story to tell about the image, you will never forget the 6 Ds of hypertrophic form of neurotrophic joint disease. And again, radiographic name for this sometimes is the Charcot joint, sometimes a bag of bones. I like bag of bones because it's clearly very descriptive. Here's another example of neurotrophic joint disease here, where we can see the bases of the metatarsals are involved. The cuneiform group certainly involved. They've acquired as a weight-bearing image. They've acquired what's called the rocker bottom foot. This can be produced sometimes in a dysplasia, but in this case, this patient had at some point in their life a normal-looking foot, but now the degree of destruction and damage done, the midfoot kind of drops down, producing this rocker bottom presentation. Neuropathic arthropathy, sometimes called Charcot joints, really aggressive. They can progress relatively rapidly. Definitely a deforming form of osteoarthritis for sure. And then some combination of repetitive trauma, peripheral neuropathy with impaired perception of injury, and ischemia. So I think this process, particularly in the diabetic patient, who is the largest contributor to lower extremity neurotrophic joint disease, is they really start with vascular insufficiency. And that's what allows nerve endings to die as a consequence of diabetes and the increased sugar load and so on. And that's what impairs the peripheral nerve endings and their proprioception and pain representation. And then that allows normal activity to produce essentially a repetitive trauma event. Since the joint surfaces don't know where they are in relationship to each other, they don't move smoothly together, and they literally collide and bang themselves apart. Now, diabetes, again, is by far the most common cause. Forefoot, midfoot, and ankle, but really anywhere in the lower extremity. But what I've shown you so far are the best and most classic examples. We do have a little differential consideration between neuropathic osteoarthropathy or osteomyelitis. And one of the cruel twists of fate is that both of these can occur in a diabetic patient. After midterm in the infection section, I'll show you an example of a patient that had underlying neurotrophic joint disease and then overlaid that process with septic arthritis. Let me take a look at MR images in these differential scenarios. One of the things that we can easily identify in an infection, osteomyelitis, is a sinus tract, replacement of soft tissue fat, fluid collections, marrow abnormalities. There's other things that will go along with that, but MR images are satisfactory in separating the neuropathic arthropathy from the osteomyelitis. Syringomyelia, again, this tends to concentrate its radiographic presentation in the upper extremity. It's affected in 80% of the cases of syringomyelia, and about 25% of patients with a syrinx will develop this form of neuropathic arthropathy. And it does tend to be more likely the atrophic form, where we get the pseudo-surgical appearance of the humeral head or the surgically amputated view. And then in other extremities, we can sometimes see candy-lick or candy-stick appearance. We can have some evidence of cervical lumbar spine affected, but early on, it really just looks like garden variety discogenic spondylosis. But the progressive changes make it more and more clearly evident that we're dealing with something different. Tabes dorsalis, or tertiary syphilis. This was actually where Charcot did his original work, and his description of neurotrophic arthropathy really came out of the tabes dorsalis or tertiary syphilis infirmaries. We see a certain predilection for lumbar spine, and it can produce what's called the tumbling spine presentation. A little less common in the thoracic spine, and there are some effects in the lower extremity, but I will tell you these days, your first thought for lower extremity involvement really should be the diabetic patient. I've had us talk about alcoholism in the last several years. It's rising in frequency, and it could be just simply we're recognizing the relationship between a drinking alcoholic and the problems associated with that and neuropathic arthropathy. We do see very common presentation of peripheral neuropathy in drinking alcoholics, but only about 30% of them will end up with a neuropathy. Findings and pattern involvement very similar to those of the diabetic patient, but with the clear differences in history and lab finding. This is some examples of a collection of CSF in the center of the cord of syrinx. Here's a little longer one, and I would say this is problematic for sure, but this will cause more widespread damage because it's involving much more length of the spinal cord. Another key feature, this actually could be what we get first. We might be dealing with a post-traumatic patient. This could be a backseat occupant without airbags in a motor vehicle accident, and their whiplash may be sufficient to create conditions for a syrinx collection and resulting syringomyelia. So as part of our exam of a post-traumatic patient, we're out there going to do the orthoneural testing, and it could be in that setting that we identify the cape-like or shawl-like distribution of sensation loss. So you start your pinwheel exam up here, feel it just fine, get down here, nothing, and then it reemerges again. Again, doing the back, feel it fine up here, nothing, and then feel it again. Now, we do tend to have it. It could be a little more limited presentation like we see this AP view, but can also involve a bigger length. It does vary from patient to patient and is most likely related to the size and compressibility of the syrinx as it affects the cord from the inside out. We do have some primary or congenital conditions, the so-called Arnold-Chiari malformation. This is usually a big foramen magnum that allows the brain to kind of settle down in the foramen magnum, and it ends up being somewhat obstructive. We also have a longer list of secondary lesions where trauma, of course, stands out as the most common. Post-infection, cord tumors, post-spinal surgery, tether cord, post-myelography, these are all associated with syringomyelia. But trauma, if they've had spinal surgery, you should move that up in your thought, and it really is technically a form of trauma. If they've had a myelogram, move it up in your thinking as a recognized complication of myelography. These other entities are much less common and will have other presenting signs and symptoms. Very good example. So here you got obviously the scapula, what's left of the glenoid, where the humeral head should be. We just have apparently a space, and then here's that surgically amputated view. It's so neatly taken away. Also see a little bit distractive injury at the acromioclavicular joint. Now, one of the things that we recognize here is that in the atrophic form, we believe this process happens slower. It gives the body time to kind of clean up the debris, macrophage activity and osteoclast activity. We think osteoclast activity is driven faster and further by the increased blood flow that sometimes is associated with this form of injury. Again, the little more typical neurotrophic, hypertrophic form with our bag of bones, just showing you some examples of rocker bottom foot and evidence over on the lateral view. And we took a closer look at the lateral view in the initial diagram. This is the same patient's foot in the oblique presentation. And we can see in this case, the lateral cuneiform obviously affected, and then what's left of the navicular calcaneus, talus and calcaneus, with a lot of debris that Lord only knows where they came from, and some evidence again of the joint distension. Again, just another example of neurotrophic joint disease. As I mentioned previously, this is referred to as a surgically amputated view. In other body parts, we can sometimes see a tapering, as if they took candy stick and then patiently licked it to a point. And we think increase in intraosseous blood flow will stimulate osteoclast, but we also recognize that if there's debris formed, macrophages can phagocytize the debris and clean up after itself. Another entity in our last section of the degenerative subcategory group is something known as synovial chondrometaplasia, sometimes referred to as synovial osteochondromatosis, primary synovial chondromatosis, less commonly synovial chondrometaplasia. This is the phrase I use most often, synovial chondrometaplasia. I like it because it does give me some insight into what's going on. We've got a change in tissue. We've got some hypertrophic change in the synovial lining, and we have kind of a chondral component to it. So overall considered to be a rare disease, proliferation in the synovium, undergoes metaplasia, and we get bone-forming cartilage. Again, hopefully you can appreciate why this is a useful name and helps explain pathomechanics. Typically monostotic, but every once in a while we'll find other companion joints involved. Knee, hip, elbow are more common targets. Every once in a while the TMJ. TMJ cases tend to make the literature because they're so uncommon. Overall, we can't explain it. We have no ability to predict who's going to get this, why they have it. We still have more to learn. Here's an example of both in the hip and in a different patient's shoulder. And again, it looks like there's just a bunch of small joint mice in here, right? And this is one of the classic presentations. This is far too much joint mouse to be a post-traumatic finding. So this view actually makes it quite easy to say synovial chondrometaplasia. Now, why would you ever go looking for this? Mostly, I consider this to be silent, but these joint mice can break off the synovial lining and become mobile. And I would say particularly in the shoulder, a patient might reach up for something on a top shelf that would tend to close the superior measure, but open the inferior glenohumeral joint space. And that could allow joint mouse to work its way between the articular surface, producing joint locking. Joint locking is by far the most common presenting complaint. And usually it's a repeated episode, because if it happens once, they just wonder what's going on, but that's it. Down with the hip, I very often hear about the patient bending over, so hip flexion essentially, whether they brought the knee to their chest or if they bent down to pick up a newspaper or pull a weed. And then when that open packs the joint, remember, there's kind of a spiral winding nature to the joint capsule of the hip. Well, as it flexes, it unwinds, creates a little joint laxity. And again, we can have a mobile joint mouse work its way in between the articular surfaces, again, producing that joint locking. We know that minor trauma can cause nodules to be shed. So trauma doesn't produce synovial chondrometaplasia. Trauma breaks the nodule loose. It was already there, it already changed, already overgrew. Make sure, now we do have some traumatically induced joint mice, but they are because portions of the articular surface has been broken off, and they look different, their history is different. The disease process can also involve tendon sheaths and sometimes bursal sacs, but mostly I would want you to think about this as an intra-articular process. Cartilaginous, intra-articular, loose bodies float freely, particularly if they've been broken loose by even trivial trauma. They are within synovial fluid, and this is what provides the nutrition and allows some growth to occur, so they can get bigger over time. Progressive enlargement and ossification occur, which make them more rigid and better able to act as a kind of a door stopper, again, produce joint locking. If they remain free, they'll grow larger, more calcified, and they can start distending joint capsule, and they can start producing discomfort. But again, I really want to emphasize the joint locking. It's by far the most common presenting feature. In the most severe cases, they have such a large number of these free joint bodies, loose bodies, that they really fully involve the interior joint space, and they can even be forced through and into adjacent tissues. We also know they can deposit in the synovial lining. They can reestablish blood supply. Now they become a real bone, not just kind of a bone-like or a bone precursor, but they can become real bone, and that needs to be surgically remedied. There are times where we know the patient has synovial chondrometaplasia. We suspect reattachment has occurred, and now in that environment, resorption of the cartilage fragment as a product of cleanup, if you will, by cells that now recognize it as an abnormal presentation. And hopefully I've got enough reps on this now. This is a little more challenging because it's a smaller number. It really is more than you would commonly see in a post-traumatic production of a loose body. But you do have to stop and think, could this be post-traumatic? Well, the lateral view, particularly knee, is going to be the most helpful. When you have this many debris fragments, you are certainly going to be able to appreciate irregularity in the articular contour. And we don't see that at all in either the tibia or the better demonstrated femur. So in this smooth articular environment, it's easy to say, no, this is consistent with synovial chondrometaplasia. And that, my friends, ends the degenerative series of lectures 1 through 6. Be sure to do the attendant study guide questions that I've created to follow each subsection. That will definitely give you some guidance as to what I think is important and therefore testable. So keep working. Let me know if you have any questions, run into any problems, and we'll get through this together.